It's time for another 3-question warm-up. Let's get going. First question here, what drug categories have the following endings? So the first one is going to be alol. Those are going to be your beta blockers. Oxin is going to be the cardiac glycoside digoxin. Pril is going to make you think of ACE inhibitors. Tadine are going to be your H2 blockers. And then tropin in general is going to refer to pituitary hormones. Next question. Which alpha adrenergic antagonists are used in the treatment of pheochromocytoma? And that's going to be probably either using phenoxybenzamine or phentolamine. Next, why do the kidneys retain fluid in heart failure patients? Well, basically you have renal hypoperfusion. It's going to lead to activation of the renin, angiotensin, aldosterone system. So if your heart isn't pumping, you're underperfusing that kidneys, and then the JG apparatus recognizes that and secretes renin. Renin converts angiotensin to angiotensin 1, and then ACE is going to convert AT1 to AT2, and then that AT2 is going to signal the adrenals to secrete aldosterone, and then that great aldosterone is going to cause those kidneys to reabsorb sodium and then water. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about bones. We'll start by reviewing how bones are formed, and then we'll focus on the different kinds of bone tumors. Now, there are a couple of basic mechanisms by which bone is formed, which are called endochondral ossification and membranous ossification. Endochondral ossification is where chondrocytes lay down a cartilage frame for the bone first, and then the osteoblasts and osteoclasts come in and they sort of lay down the bone matrix later. This occurs mainly in the axial skeleton and in the limbs. And you know that children have epiphyseal plates on the ends of the long bones to allow the bones to lengthen. That's an example of endochondral ossification. Then sometime in adulthood, those plates fuse and the bones can't grow any longer. And then membranous ossification is where the osteoblasts and osteoclasts build the bone directly without that cartilage frame. This occurs in the skull and the facial bones. If there's a defect in the endochondral ossification in those long bones of the axial and appendicular skeleton, that's achondroplasia. This results in short limbs with the proximal segments of the limbs being shorter than the distal segments. The limbs are also disproportionately smaller than the trunk, and the head is disproportionately large. These individuals also have frontal bossing or a prominent forehead, and you can often see bowing of the tibias. Achondroplasia is caused by activation of a fibroblast growth factor receptor called FGFR3. It's a gain-of-function mutation, which means that instead of the mutation causing a protein that's unable to do its job, the protein has enhanced function or a new function. It's gained a function. In this case, the gain of function is that the growth factor receptor is constitutively activated, which means it's always switched on. That activation inhibits chondrocyte proliferation, so they don't lay down those cartilage models of the bone correctly. Now, the majority of these mutations occur sporadically, and they're associated with advanced paternal age. So the older the father is when they have a child, the more likely that child is going to have achondroplasia. Now, individuals with achondroplasia have normal life expectancy and normal fertility. That mutated FGFR3 gene, even though it arose sporadically in the father, can be passed on in an autosomal dominant fashion. So let's think through the genetics of this. Let's let big A be our autosomal dominant mutation that causes achondroplasia. So what gene was that? FGFR3. So big A is a mutation and little a is the wild type, the non-mutated gene with average height. If an achondroplastic patient has a child with a spouse that has a normal stature, what's the likelihood that their child will have achondroplasia? So we have to assume that the achondroplastic spouse is heterozygous for the mutation, so there's a 50-50 chance of passing on that mutated gene and having an achondroplastic child. But if you have an achondroplastic couple who had a child, so mom and dad both have achondroplasia, what would be the likelihood of having an achondroplastic child in that scenario? So again, assuming that the parents are both heterozygotes, there would be a 25% chance that the child would have normal stature and would not be affected. There would be a 50% chance of the child being heterozygous and therefore achondroplastic. And there would be a 25% chance that the fetus would be homozygous for the mutated gene and would therefore die in utero. That's why it's pretty safe to assume that both of these parents were heterozygotes to begin with, because homozygotes don't survive. So although fertility is not necessarily affected, when you have two patients with achondroplasia wanting to have a baby, there's a 25% chance that that fetus will be homozygous and is going to die in utero. 2/3 of the babies born to these couples will be achondroplastic. And when an achondroplastic woman is pregnant, we generally deliver by C-section, because if that baby is a normal phenotype,
The mom's pelvic outlet may not be wide enough to accommodate the baby, so deliver by C-section. I also want to review some basics on how bones heal following a fracture. This has shown up on Step 1 in recent years. We can think about bone healing in 3 phases, although there's a lot of overlap, so it's not quite as cut and dry as this table makes it seem. The first phase of bone healing is the inflammatory or reactive phase. In this phase, there's a hematoma that forms, and then osteoclasts move in to resorb 1 to 2 millimeters of bone on each side of the fracture. This takes a few days, which is why fracture lines often show up better on x-rays taken a week after the fracture rather than immediately after a fracture. And the space between the 2 faces of the bone is basically filled in with granulation tissue. And then multipotent cells from the periosteum move in and are converted to osteoprogenitor cells. The second phase is the reparative phase. This is where new blood vessels start to form outside the bone and then work their way in to provide nutrients to all those cells and to provide the minerals and things needed. And chondroblasts and fibroblasts move in and start to lay down cartilage and type 1 collagen to fill in the gap between the fractured edges. And eventually this cartilage starts to undergo endochondral ossification and becomes organized into what's called a callus. Then the third phase of bone healing is the remodeling phase. During the remodeling phase, that callus continues to become ossified, and then the new bone is extensively remodeled by osteoclasts and osteoblasts. We'll talk more about those cells in the next video.
Now let's talk about bone tumors. Most tumors that occur in the bone are metastatic tumors that originated somewhere else, like breast cancer or prostate cancer. We'll get to those later. But first I want to talk about primary bone tumors, which are tumors that arise in the bone or in the cartilage itself. You're likely to see questions where you have to recognize the tumor based on its appearance on x-ray and also its location. Now, make no bones about it. Bone tumors can be a little tricky, but I'm going to throw you a bone and give you some bare bones facts about each kind of tumor. Just the material you need to bone up on. I want to make it easy for you. No reason to work your fingers to the, well, you get the idea. Let's start with osteochondroma, which is the most common benign tumor of bone. It tends to occur in young males under 25. These look like big bone spurs with a cartilage cap on them. This is a benign growth of normal tissue in a normal location, which means this is a type of hamartoma. A hamartoma is a benign tumor of disorganized tissue in its normal location. You can have hamartomas in the lung, in the heart, and so on. So an osteochondroma is a kind of hamartoma of the bone. And fortunately, it's very rare that these benign osteochondromas become malignant chondrosarcomas. Next is an osteoclastoma, or a giant cell tumor of the bone. This is a tumor that contains multinucleated giant cells that resemble osteoclasts, the bone cells that break down the bony matrix. That's why it's sometimes called an osteoclastoma. But it's thought that these giant cells are derived from circulating monocytes that are recruited to the tumor and then sort of changed to resemble osteoclasts. Osteoclastomas occur in slightly older individuals, young adults ages 20 to 40. I'm old enough that I still consider 40 to be young. These are usually located on the distal femur or the proximal tibia, so near the knee. And you get something called a soap bubble appearance in the bone on x-ray. On this x-ray, down here in the proximal tibia, you can see this roundish lucency, which is the soap bubble appearance. It's a lucent lesion because those osteoclast-like cells are breaking down the bony matrix. And on the microscopic view, you can see the multinucleated giant cells and the mononuclear cells in the stroma. The next primary bone tumor I want you to know about is an osteosarcoma. Now, sarcoma tells you this is a malignant tumor. Osteosarcoma is the most common malignant primary bone tumor. It's less common than a multiple myeloma, but I don't really think of myeloma as a bone tumor per se. Myeloma isn't even really a tumor or a mass. It's a proliferation of plasma cells within the bone marrow. So anyway, the most common real primary bone malignancy is osteosarcoma. It's associated with the hereditary retinoblastoma gene mutation. Retinoblastoma is a malignancy of the retina, but individuals who have that mutation are also at risk of getting osteosarcoma. We'll talk about retinoblastoma again in the oncology videos. Osteosarcoma is most common in teenage boys, ages 10 to 20, and it's also seen in adults over 65. And then there are 2 x-ray findings you should know.
There's Codman's triangle, which is where the tumor pushes the periosteum up from the surface of the bone, forming this little triangular density on x-ray. And there's this classic sunburst pattern to the tissue, which is kind of pretty to look at, except it's a cancer that's going to kill you.
One last primary bone tumor to mention is Ewing sarcoma. Again, sarcomas are malignant by definition. Ewing sarcoma occurs in young boys under 15, and it's extremely aggressive. Ewing sarcomas tend to grow on the surface of the cortical bone, along the shaft of the long bones. And on X-ray, you can see this destruction and disruption of the cortex. And that disruption of the cortex gives this classic onion skin appearance with what looks like layers of an onion. And you should also know that Ewing sarcoma is associated with the 1122 translocation. All right, that's it for the primary bone tumors. And before we talk about metastatic disease to the bone, let's do a whiteboard review.
We've talked about 4 different primary bone tumors with a whole bunch of different patient populations and different X-ray findings and so on. So it's pretty easy because all you really need to know for step 1 are the buzzwords, but then you have to keep the buzzwords straight in your mind. So let's review these. First of all, which ones are benign and which ones are malignant? The benign ones are the osteochondroma, the osteoclastoma, and the malignant ones are the sarcomas, the osteosarcoma and the Ewing sarcoma. Then for the age groups, Ewing sarcoma seen in the youngest patient, under 15. Osteosarcoma, also seen in fairly young patients, ages 10 to 20. So the younger they are, the more likely they are to have a malignant primary bone tumor. And then for the osteochondroma, those are seen in patients less than 25, and osteoclastoma is seen in patients aged 20 to 40. And then for these radiographic appearances, for osteochondroma, that's the chunk of bone that's kind of stuck on the end of the bone, kind of around the knee. Codman's triangle is seen in osteosarcoma. The onion skin appearance is seen in Ewing sarcoma. Soap bubble was seen in osteoclastoma. And then the sunburst was osteosarcoma as well. Then one other thing to help you remember these X-ray findings. A student sent in this great mnemonic. The S and C in osteosarcoma reminds you of sunburst and Codman's triangle. Then the CH in osteochondroma reminds you that this one is a chunk of bone that's stuck on to the surface of the affected bone. And then the CL in osteoclastoma, CL is for clean, like soap makes things clean. So the soap bubble appearance is seen in osteoclastoma. And then for Ewing sarcoma, some students like to think about eating chicken wings and onion rings, which is a pretty good mnemonic, but it also makes me hungry. All right, very good job on these. And as your reward today, I'm going to give you a gold star made out of gold stars. Primary bone tumors are relatively uncommon. The majority of tumors you find in the bone are metastatic tumors. They started somewhere else and then they metastasized to the bone. So what kinds of mets are we talking about? Well, students sent us a good mnemonic for these. Permanently relocated tumors that like bones. The P is for prostate, the R is for renal cell cancer, the T's in tumors and that stand for 2 things, testes and also thyroid. The L is for lung and the B is for breast. So lung cancer and breast cancer love to metastasize to other organs like the bone, also the brain and the liver. And then also note the genitourinary association here. Prostate, testes, and renal cell cancer all like to go to the bone. Now clinically, it's important to know that some of these are lytic bone lesions, which means they're breaking down the bone at the site of the mets, kind of like we saw with osteoclastoma. And then some bone mets are blastic. They actually build new bone, but that new bone is disordered and weak and it fractures easily. So renal cell carcinoma mets and thyroid cancer mets to the bone tend to cause lytic lesions. Prostate cancer causes blastic lesions. And then breast cancer mets and lung cancer mets to the bone can either be lytic or blastic. And what are the clinical manifestations of bone mets? How are they going to present? Well, you can have bone pain. You can have epidural spinal cord compression, where a tumor in the vertebral body invades the epidural space and compresses the thecal sac in the spinal cord, which causes pain, sensory deficits, motor deficits, and bladder or bowel dysfunction. And then lytic bone mets cause hypercalcemia from the destruction of the bone. And now it's time for the end of session quiz. So pause the video, work through those questions, then restart the video and we'll go over them together.
First question. Where does new bone formation take place in growing long bones? Well, it takes place at the epiphyseal plate, where cartilage is being formed, and then that cartilage is transformed into bone. Next, Which primary bone tumor fits each of the following descriptions? The most common malignant primary bone tumor of children is osteosarcoma. Multiple myeloma, if you're going to count that as a bone tumor, is a disease of the elderly, not children. So osteosarcoma is most common. The most common benign bone tumor is an osteochondroma. 1122 translocation is associated with Ewing sarcoma. The retinoblastoma mutation is associated with osteosarcoma. Sunburst pattern on X-ray is an osteosarcoma. A soap bubble appearance on X-ray, remember soap is clean, so that's an osteoclastoma. And then onion skin appearance of the bone, wings and rings, that's Ewing sarcoma. May actually be a hamartoma, is osteochondroma. Remember, that's that chunk of bone and cartilage just stuck on the end of a bone. And then Codman's triangle on X-ray is osteosarcoma.
And the last question, what mutation leads to achondroplasia? It's a gain of function mutation on FGFR3, fibroblast growth factor receptor 3. And that's all for now. I'll see you next time.
Hello everyone and welcome to another warm-up review. Let's get going. What is the common mechanism of action for the following drugs? And what is the clinical application for each? Now all of these are going to be anticholinesterases which inhibit the enzyme acetylcholinesterase. So that acetylcholine is going to end up staying around longer. So the first one here is neostigmine. That can be used to treat myasthenia gravis and to reverse neuromuscular blockade in anesthesia. You can also use neostigmine to treat post-op urinary retention. Next we have physostigmine. That's going to be used to treat anticholinergic poisoning like atropine poisoning. Pyridostigmine. That's used to reverse neuromuscular blockade, also to treat myasthenia gravis. Remember the mnemonic, pyridostigmine gets rid of myasthenia. But pyridostigmine lasts much longer than neostigmine. And then rivastigmine is used to treat Alzheimer's disease. Next, when placing a femoral venous catheter while palpating the pulsatile femoral artery, where is the femoral catheter placed in relation to the artery? So remember we have the mnemonic navy or navel, depending on which one you like. Remember that the femoral nerve is lateral to the artery and the femoral vein is medial to the pulse. So palpate the femoral artery and then insert your needle medial to the artery. Next, what are the different mechanisms by which heart contractility can be increased? So there's lots of different things that can increase heart contractility. The main one is catecholamines. So anxiety, exercise, stress, or catecholamine infusion are all ways that catecholamines will be increased. Increasing your intracellular calcium can increase heart contractility. Decreasing your extracellular sodium can do this. And then digoxin accomplishes both of these. It both increases intracellular calcium and decreases extracellular sodium. All right, that's it for the review. Let's get to that video.
In this video, we're going to review some bone disorders, especially diseases of bone mineralization, like osteoporosis and rickets, which are fairly high yield for step 1. Let's start with some basic bone biology. The calcified, mineralized parts of our bones are constantly undergoing revision and turnover by cells that live within the bony matrix. The osteoblasts are cells that lay down a matrix of collagen, and then they catalyze the mineralization of that matrix. So remember the B in osteoblast for building bone. And as the osteoblasts surround themselves with this bony matrix, they get incorporated into the bone and they become osteocytes. Now osteocytes live in these little gaps in the bony matrix called lacunes. A lacune is like a little lake or a lagoon inside the bone. And then they contact and communicate with one another via these tiny canals in the bone matrix, which are called canaliculi. Osteoclasts are the cells that break down that bony matrix to remodel it, to heal fractures and so on. Osteoclasts are found at the surface of the bone, and they're derived from a macrophage cell lineage, so they're kind of eating away at the bony matrix. Osteoclasts are multinucleated. When you get several macrophage-derived cells together and they fuse their membranes to become one of these enormous multinucleated cells, we call that a multinucleated giant cell. Remember that osteoclastomas, those soap bubble tumors, are also called giant cell tumors. Let's talk about a very common disorder of bone mineralization, osteoporosis, which is about a 4-star topic. Osteoporosis is basically caused by an imbalance between the actions of the osteoblasts and the osteoclasts. Normally, the osteoblasts work just as fast as the osteoclasts do, but if the osteoblasts slow down while the osteoclasts keep working normally, you end up with increased resorption of bone and reduced bone mass. You're gradually eroding the calcium matrix away from your bone. This typically occurs in older age, especially in postmenopausal women. Osteoporosis develops slowly, gradually over time. And people usually don't know they have osteoporosis unless they get a bone mineral density test, which is also called a DEXA scan, a dual energy X-ray absorptiometry scan. You're basically measuring how much X-ray radiation is passing through the bone at the spine or at the hip. If the bone is nice and healthy and dense, it's going to absorb a lot more of the X-rays. But if most of the X-rays pass through the bone, you know that that bone mass is reduced.
The problem with osteoporosis is that this weak bone is prone to fractures. So the patient might fall and break a hip or land on her hand and fracture her distal radius like you see here. Now this is called a Cole's fracture, where the distal radius is fractured and the hand slides dorsally. Or sometimes you'll hear it called a dinner fork fracture because that's what it kind of resembles. The hand and the wrist sort of resembles the shape of a dinner fork. Now these patients can also present with vertebral compression fractures, which may or may not be painful. But these compression fractures eventually lead to pronounced kyphosis and loss of height. This is one of the reasons that older people seem to be shrinking.
Let's look at the study guide and talk about how we treat osteoporosis and prevent those fractures. First of all, there are some simple lifestyle things like quitting smoking, avoiding long-term steroid use, and increasing exercise, especially weight-bearing exercise. Weight-bearing puts torque and strain on the bones, and that stimulates the osteoblasts a little bit. Calcium and vitamin D supplements are very important. And the number one mainstay therapy for osteoporosis is bisphosphonates, which decrease fracture risk by 40 to 50%. Let's pause right there and talk about bisphosphonates for a moment, since they're the number one treatment. Bisphosphonates end in the suffix dronate, alendronate, residronate, etidronate. They work by inhibiting osteoclast, and by inhibiting bone resorption, they're going to allow the osteoblast to kind of catch up and build more bone. We mainly use bisphosphonates for osteoporosis, but occasionally we use them in Paget disease of the bone and in something called humoral hypercalcemia of malignancy, which is where certain types of cancer make a hormone called PTH-related peptide, or PTHrP. And that hormone stimulates the osteoclast, which leads to hypercalcemia as a paraneoplastic effect. But if you give a bisphosphonate to that patient, it's going to inhibit the osteoclast. And since long-term steroids can cause osteoporosis, sometimes we give bisphosphonates to patients who need to be on long-term steroids to prevent that. And then for side effects, one of the potential problems with bisphosphonates is that they can cause erosive esophagitis. So patients have to take the pill in a certain way and make sure it washes all the way down to the stomach. And there's an extremely rare condition called osteonecrosis of the jaw, where the bone in the jaw starts to die, which really only shows up as a complication of jaw surgery or dental surgery. So sometimes oral surgeons won't do elective jaw surgery until the patient's been off the bisphosphonate for 6 months or so. So those are the details worth knowing about bisphosphonates. Remember, bisphosphonates are your number one go-to drugs. The rest of these treatments in the study guide are used a little less commonly. If you're treating a woman, you can give estrogen. Estrogen does reduce fracture risk, but it's not recommended to give estrogen only to treat osteoporosis. There are too many other risks involved. But if there's some other reason for the woman to be on estrogen, the estrogen will help the osteoporosis. The SERMs, or selective estrogen receptor modulators, like raloxifene, will decrease the incidence of vertebral fractures. There's a drug called teriparatide, which is a parathyroid hormone analog. And if you give PTH continuously, it erodes bones. But if you give pulsatile PTH, it stimulates osteoblasts. So you can give a daily subcutaneous injection of teriparatide, and that will decrease hip fracture rates by 53%. But you can't give this drug for more than 2 years because of an increased risk of osteosarcoma in experimental rats. So this is a shot that the patient gives herself every day for 2 years, and then after that she needs to be on a bisphosphonate to maintain the bone that she's built up. There's also a drug called denosumab, which is a rank L inhibitor that inhibits osteoclast activity. Next, let's talk about osteopetrosis. If osteoporosis is porous, weak bones, then osteopetrosis is rock-like bones, bones that are too thick, too dense. Petra is Greek for rock, like petrified. Osteopetrosis is a defect of bone resorption. The osteoclasts are deficient in the enzyme carbonic anhydrase 2, and that means they have trouble breaking down the bone matrix. So in osteoporosis, the osteoblasts were falling behind. And here in osteopetrosis, it's the osteoclasts that are falling behind. But oddly enough, these petrified rock-like bones can be prone to fractures as well because the bone matrix tends to be disorganized and unhealthy. Now on X-ray, you can see the long bones tend to flare out on the ends, kind of like an Erlenmeyer flask. And this bone overgrowth can cause the foramina of the skull to become narrowed, which can trap the cranial nerves and cause cranial nerve palsies. The thickening of the bones can also obliterate the marrow space, leading to pancytopenia. So you have low levels of all blood cells. You have anemia, leukopenia, and thrombocytopenia.
For step 1, you also need to know how all these bone diseases affect the labs, especially calcium, phosphate, alkaline phosphatase, and PTH. So in osteoporosis, you're going to see normal labs. In osteopetrosis, you generally see normal labs as well. If the osteopetrosis is really severe, serum calcium might be slightly low, and that might cause some secondary hyperparathyroidism and raise the PTH a little bit, but for the most part, serum calcium levels are going to reflect dietary intake. So as long as the patient has adequate calcium intake, serum calcium should be pretty normal. And in some forms of osteopetrosis, ALK Phos might be slightly high, but for the most part, the labs are going to be normal. We're going to go over the labs again in detail a little bit later on. Let's move on to Paget disease of the bone, which is completely unrelated to Paget disease of the breast. Same Dr. Paget, two different diseases. Paget disease of the bone is a disease in which there's increased activity of osteoblasts and osteoclasts, and this leads to localized disorganization of the bony architecture. So the osteoblasts and osteoclasts are out of harmony, and this causes localized bone lesions throughout the skeleton. Now, one of the buzzwords you may see is that this disorganized bony architecture has a mosaic pattern or a haphazard pattern. If you see it described as mosaic pattern or haphazard pattern, think Paget disease. So again, with osteoporosis, the osteoblasts were working too slowly. With osteopetrosis, the osteoclasts were working too slowly. And in Paget disease, first the osteoclasts are activated and they start tearing down the bony matrix. And then eventually this activates osteoblasts to try to catch up by laying down new matrix. And then over time, the osteoclasts kind of burn out and only the osteoblasts are working overtime. So the result is disorganized bone remodeling. Now, most patients with Paget disease have no major symptoms, although they might potentially have bone pain, bone deformities, and fractures.
One interesting presentation you might see on your exam is a patient who complains that his hats are getting tight or that he has increased hat size because the cranial bone is just getting thicker and thicker. These patients can also have narrowing of the auditory foramen, which leads to hearing loss, kind of like we saw with osteopetrosis. And these patients are at an increased risk of developing osteosarcoma, which kind of makes sense if you think about focal areas of disordered bone growth leading to bone cancer. For the labs, calcium, phosphate, and PTH levels will all be normal. This is not due to a problem with PTH. But ALK Phos will be high because of all this excessive bone turnover. ALK Phos can be high because of bone disease or liver and biliary disease. There's an intestinal ALK Phos and there's a bone-specific ALK Phos. The routine ALK Phos lab test that you order measures both, although you can measure them separately. Bone-specific ALK Phos reflects osteoblast activity. So an elevated bone-specific ALK Phos is a marker of bone formation. In osteoporosis and osteopetrosis, the osteoblasts aren't working any harder than normal, so the ALK Phos is normal. But in Paget disease, once the osteoblasts do get ramped up, the ALK Phos is going to be high. Let's move on to osteomalacia and rickets, which are both caused by vitamin D deficiency. In children, vitamin D deficiency causes rickets. In adults, vitamin D deficiency causes osteomalacia. So vitamin D promotes calcium absorption in the gut. So with vitamin D deficiency, you're going to have poor calcium absorption and low serum calcium. And that low serum calcium causes poor mineralization of the bone, so that the bones are kind of soft, and you might see some bowing of the long bones. Now, what about the rest of the labs? Well, as you decrease serum calcium levels, PTH will increase. PTH is going to stimulate the osteoclast to break down that bony matrix and release some calcium into the serum. And PTH also increases reabsorption of calcium in the renal tubules. But then PTH is going to decrease serum phosphate by taking phosphate out of the serum and dumping it in the urine. You can remember that PTH is phosphate trashing hormone. PTH will always try to reduce serum phosphate levels. And then because your PTH is high, you have increased bone turnover. And anytime you're increasing turnover of bone, you're going to see elevated alkaline phosphatase. So ALK Phos will be normal or slightly high also. And speaking of PTH, let's talk about osteitis fibrosa cystica, which is found in your study guide. Osteitis fibrosa cystica is also known as von Recklinghausen disease of the bone. Now, this is completely unrelated to neurofibromatosis, which is also called von Recklinghausen disease. Anyway, osteitis fibrosa cystica is a bony manifestation of an endocrine disorder, which comes about in patients with either hyperparathyroidism or pseudo-hypoparathyroidism. We're going to cover both of those in the endocrine videos. But with hyperparathyroidism, you have high PTH, and that results in high serum calcium and low serum phosphate and high alk phos. With pseudo-hypoparathyroidism, specifically type 1A pseudo-hypoparathyroidism, also known as Albright hereditary osteodystrophy, your renal tubules are unresponsive to PTH. So this looks a lot like hypoparathyroidism, low serum calcium and high phosphate. But the parathyroids are perfectly capable of making PTH, so that low calcium is going to stimulate PTH production, and PTH will be high. So with either of these conditions, PTH is going to be high. In either case, that high PTH leads to excess osteoclastic activity, and that eats away at the bones to cause these cystic lesions. So it's osteitis fibrosa cystica. These cystic lesions show up as brown tumors in the bone, which are really these cystic spaces that are lined with multinucleated osteoclasts, and they're filled with blood and also filled with some fibrous tissue. So that's the fibrosa in the name. And the DEXA scan reveals low bone mineral density, but with a very different mechanism of bone loss than we see in osteoporosis. Then one more bone disorder is something called polyostotic fibrous dysplasia. So this is dysplasia of the bone, fibrous dysplasia, where the bone's replaced by collagen and fibroblast. So there are irregular bony trabeculae. So the ratio of collagen to calcium in the bones is high. There's more collagen than there ought to be. This is one part of McCune-Albright syndrome, which is characterized by three things: precocious puberty, café au lait spots, and this fibrous dysplasia of the bone. And don't confuse that with Albright hereditary osteodystrophy. They're two different things. Let's compare the lab findings in these major bone disorders. There's a table in your study guide for you to fill out. This is very high yield, 4 or 5 stars. Make sure you know these.
In osteoporosis, everything is normal. Serum calcium's fine, phosphate's fine. You're not having any high bony turnover, so alkaline phosphatase is fine. And then PTH is fine. So with osteoporosis, you have decreased bone mass over a long period of time, so the labs are going to be normal. In osteopetrosis, again, the lab values are usually pretty normal. Maybe calcium's a little low, and maybe PTH is a little high, and maybe alk phos is a little high. But basically, you just have extra thick, dense bones. In Paget's disease, you have increased bony turnover, so alk phos will be elevated. But it does not affect calcium, phosphate, or PTH. This is not a PTH problem. It's not a calcium problem. With rickets and osteomalacia, there's deficiency of vitamin D. And that leads to decreased calcium absorption, so serum calcium is decreased. And as a result of that, PTH goes up. As PTH goes up, you start to trash phosphate, so phosphate goes down. And this can result in either a normal alk phos or a high alk phos, depending on how high your PTH levels are. A similar picture occurs with renal insufficiency. With renal insufficiency, one thing that happens is your kidneys can't convert hydroxyvitamin D to dihydroxyvitamin D, which is the active form. So renal insufficiency starts out looking like vitamin D deficiency, and you're going to absorb less calcium. And because your calcium levels are low, PTH is going to be elevated. As your PTH goes up, you'd think that phosphate would be trashed, right? Well, in renal failure, your nephrons can't get rid of phosphate. So the one lab difference between renal insufficiency and vitamin D deficiency is that with renal insufficiency, your phosphate will go up because your nephrons can't get rid of phosphate. Then there's vitamin D intoxication, where you're taking too much vitamin D over a prolonged period of time. And remember, you can't get too much vitamin D from the sun. You can get too much sun for your skin, but you're never going to get too much vitamin D from being out in the sun. So vitamin D intoxication is going to increase serum calcium level. And as you absorb more calcium, the body's going to decrease PTH secretion. As PTH goes down, you're going to increase phosphate. And then how about primary hyperparathyroidism? The underlying problem is that PTH is high. As PTH goes up, it raises your serum calcium level and it trashes your phosphate. And as PTH goes up and you get bony turnover, you're going to also have elevated alk phos levels. And then sometimes when PTH goes up, you get osteitis fibrosa cystica with those brown tumors in the bone and the bleeding into the bone. So in terms of labs, this will usually look just like primary hyperparathyroidism. Again, this is just a bony manifestation of hyperparathyroidism.
Now you're ready for the end of session quiz. So pause the video and work through those questions, and then we'll review the answers. First question, what cell type is most similar to osteoclast? Well, osteoclasts are similar to macrophages. Next, which bony disease fits each of the following descriptions? So reversible when vitamin D is replaced, that's osteomalacia and rickets because those are due to vitamin D deficiency. Excess osteoclastic activity results in disorganized bony architecture. That's Paget disease of bone. Bone is replaced by fibroblasts, collagen, and irregular bony trabeculae. That's polyostotic fibrous dysplasia. Soft bones due to defective mineralization is osteomalacia and rickets again. Failure of bone resorption causing thickened and dense bones is osteopetrosis. And genetic deficiency of carbonic anhydrase 2 is also osteopetrosis. Next, what measures can be taken to prevent osteoporosis? So we mentioned weight-bearing exercise, adequate calcium and vitamin D intake, and reduction of risk factors like avoiding smoking or smoking cessation, avoiding glucocorticoids, avoiding the chronic use of heparin, which can cause osteoporosis. I didn't mention that, but it's definitely a risk factor. And also treating any hypogonadism that may be present. And that goes for men too. Hypogonadal men are at increased risk for osteoporosis, and testosterone replacement can reduce that risk. Next, fill in the following table. Again, you need to know these. So first we have Paget disease. In Paget disease, ALK-Phos will be elevated, but PTH is normal. That means calcium and phos are going to be normal. Osteomalacia and rickets, you can have low vitamin D that results in low serum calcium, which causes elevated PTH, which is going to trash your phosphates. And then alkaline phosphatase will either be normal or mildly elevated. In osteitis fibrosis cystica, that's due to elevated PTH, which leads to an increase in serum calcium and low phosphates. And then the increased bone turnover will increase the alkaline phosphatase. And then for osteoporosis, there will be no abnormalities with any of the lab values. Then we have a couple of rapid-fire facts. Bone enlargement, bone pain, and arthritis would be seen in Paget disease of the bone, that bone enlargement where the hats don't fit anymore. And then vertebral compression fractures are most commonly seen in osteoporosis. So that's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. Which drug category has each of the following endings? So we have dronate, that's going to be the bisphosphonates like alendronate. We have chol, that's going to be the cholinergic agonist like bethanechol. Mustine, that's going to be ending for the nitrous ureas, for example, carmustine. Statin are going to be the HMG-CoA reductase inhibitors like atorvastatin. Then bendazole is going to be endings for the group of the anti-helminthic drugs like mebendazole. Next question. What are the side effects of amiodarone? So remember with amiodarone, you got to monitor the PFTs, the LFTs, and the TFTs because amiodarone can cause pulmonary fibrosis. It can be hepatotoxic, and it can cause either hypo or hyperthyroidism. It can also cause some corneal deposits, photosensitivity, neurologic effects, constipation, and cardiovascular effects. So a lot of different side effects there. Next, what conditions are associated with diastolic murmurs? So diastolic murmurs are almost always abnormal, and they can be seen with mitral stenosis, tricuspid stenosis, aortic regurg, and pulmonic regurg. All right, that brings us to the end of the warm-up. Let's get to that lecture.
In this video, we're going to talk about some assorted musculoskeletal injuries and joint problems, things like ankle sprains and tennis elbow. You'll probably see a few of these over the course of your exam. We're going to start in the hand, work our way up to the shoulder, and then go from the hips down to the feet. But first, one tiny little high-yield fact that's worth noting is that joints represent a potential space, and these joint spaces have a negative hydrostatic pressure, around -3 to -5 millimeters mercury. So in the same way that your pericardial cavity and your pleural cavity are potential spaces that have negative hydrostatic pressure that draws fluid into them, your joints also have a negative pressure. So let's review some anatomy. You definitely need to be able to identify the bones of the wrist, the carpal bones. Now, there are lots of mnemonic for these, but one good one is, so long to pinky, here comes the thumb, which is nice because pinky and thumb match up with the side of the hand those fingers are found on.
So starting with the proximal row of bones, so long to pinky stands for scaphoid, lunate, triquetrum, and pisiform. And then here comes the thumb goes back the other way toward the thumb. Hamate, capitate, trapezoid, and trapezium. And if you have trouble remembering which of those is closest to the thumb, just remember the thumb swings on the trapeze, like the trapezium.
When you punch something, or punch someone, with a clenched fist and you have tenderness in the anatomical snuff box, which carpal bone is most likely fractured? That's a scaphoid fracture. Even if the initial x-ray is negative for an obvious fracture, if there's tenderness in the anatomical snuff box, you have to presume that there's a scaphoid fracture. And the reason it's dangerous to miss a scaphoid fracture, especially one that you can't see right away on x-ray, is that blood is supplied to the scaphoid bone from distal to proximal. So if a scaphoid fracture cuts off that blood flow and you don't catch it and fix it, that can result in avascular necrosis of the proximal fragment, which can result in a painful arthritis. Let's move up to the elbow. I want to briefly discuss epicondylitis, which is inflammation of one of the epicondyles of the elbow. There's lateral epicondylitis, which is called tennis elbow. This is inflammation of the lateral epicondyle due to repetitive use that leads to small tears in the wrist extensor tendons that attach there. So it may be a little more accurate to call this a tendinopathy rather than epicondylitis. And then medial epicondylitis is injury to the medial epicondyle and the wrist flexors, and that's called golfer's elbow. Now, a student sent us a pretty good mnemonic. In golf, you aim for the middle of the fairway, the medial part of the course. And in tennis, you aim for the lateral edges of the tennis court. So golfer's elbow affects the medial epicondyle, and tennis elbow affects the lateral epicondyle. If you move just a little north of the elbow, you're going to find the biceps tendon. So let me say a word about rupture of the biceps tendon. How would a ruptured biceps tendon present? Well, the biceps tendon can tear either at the elbow or at the shoulder, and it usually occurs in relation to lifting something heavy. So first you're going to see a lot of bruising in the area, and then eventually you're going to see a muscle bulge in the mid part of the upper arm as the muscle contracts. And you might think, that looks terrible, we really need to go in and fix that. But you don't always need to fix it. If the patient's an older patient and is able to function and recover just fine, there's nothing else you have to do about it. So we don't always surgically repair a torn biceps. But if it's a young patient or if it's limiting them functionally, surgical repair is an option. This is sometimes called a Popeye lesion, which doesn't make a lot of sense to me since Popeye has big bulging forearms and not big biceps. But at least the name is memorable. And while we're talking about tendon rupture, what class of antibiotics can increase the risk of tendinopathy and tendon rupture in adults? Fluoroquinolones. They don't really increase the risk of biceps tendon rupture, but Achilles tendon rupture is certainly a known complication. It's extremely rare, but it's still worth knowing. Now let's turn our attention to the shoulder, starting with the muscles of the rotator cuff. So what are the four rotator cuff muscles? Well, they're the supraspinatus, the infraspinatus, the teres minor, and the subscapularis, which spells sits. And we use a lowercase t to remind you that this is not the teres major, it's the teres minor. Now the rotator cuff is a 3 or 4 star topic, so make sure you know those muscles. Now, which rotator cuff muscle initiates abduction of the arm, the first 10 or 15 degrees? That's the supraspinatus muscle. And the way you test for a supraspinatus injury is with an empty can test. So make sure you know this. You have the patient abduct the arm to 90 degrees, and then about 30 degrees of forward flexion, and then you try to pronate the forearm until the thumb is pointed straight down, like they're emptying a can or pouring out a 40. And you try to press the arm back down while the patient tries to resist you. And if there's pain and weakness at the same time, that suggests a supraspinatus injury. Now, which two rotator cuff muscles rotate the arm laterally or externally? That's the infraspinatus and the teres minor. Those are the lateral rotators of the shoulder. And then the medial or internal rotator is the subscapularis. Next, let's talk about shoulder dislocation and shoulder separation. Now, there's a question in the study guide that says, what's the difference between a dislocated shoulder and a separated shoulder? And they're very different in terms of which structures are involved. They only sound similar. In a dislocated shoulder, the head of the humerus rotates out of the glenoid cavity. But in a separated shoulder, it's the clavicle that's separating from the acromion process and the coracoid process of the scapula. Then the next question says, what structures can be damaged in an anterior shoulder dislocation? This question in and of itself is probably about 3 stars. With an anterior shoulder dislocation, you can have injury to the axillary nerve and the posterior circumflex artery, an injury to the supraspinatus tendon that we were just talking about with shoulder impingement. You can also injure the anterior glenohumeral ligaments and then you get some separation of the glenoid labrum from the articular surface of the anterior glenoid neck. That's called a Bankart lesion. Or you could have a traumatic defect of the posterolateral humeral head due to forceful impact against the anterior rim of the glenoid, and that's referred to as a Hill-Sachs lesion. So on the left, you see that the shoulder has become dislocated and the head of the humerus impacts the glenoid rim. And then on the right, after the dislocation has been reduced, you see this prominent vertical white line where that impact fractured the head of the humerus. That's the Hill-Sachs lesion, or the Hill-Sachs fracture. And how do we test for axillary nerve damage in an anterior shoulder dislocation? You test for sensation. You can lightly touch the deltoid region and ask if the patient can feel it. If they can't feel it, that could indicate an axillary nerve injury. So check that before you reduce the dislocated shoulder, so you know if the axillary nerve was injured before the reduction. And then you also want to check after reduction to document whether or not it was injured after the reduction. Now, whenever you put a bone back into place, that's called a reduction. If you do that without having to do surgery, that's called a closed reduction. If you surgically put a bone back into place, that's called an open reduction. And maybe you've heard the term ORIF, which is an open reduction internal fixation. That's where you not only do surgery to put the bone back into place, but you also fix it in place with a screw or a plate or a pin. So it's an open reduction with internal fixation. That's most commonly seen in fractures rather than dislocations. And speaking of fractures, and before we move from the upper extremity to the lower extremity, I want to mention a couple of types of fractures that we see in children, especially in the forearm. A green stick fracture occurs when a long bone is bent so that the cortex on one side is fractured, but the cortex on the opposite side of the bone doesn't fracture, but it kind of bends. This occurs because the bone is still immature and still relatively soft and pliable. So you see these incomplete fractures like you're trying to break a green branch from a tree and it doesn't break all the way through. And then another type of incomplete fracture is called a torus fracture or a buccal fracture. This can happen when a force is applied to the end of an immature long bone, along the longitudinal axis of the bone, and the cortex kind of buckles. So you see the subtle bowing or buckling of the cortex. And these are relatively stable, so you just have to cast them to immobilize them. Now we're ready to move from the upper extremity to the lower extremity. So the question in the study guide says, what is the most common type of hip dislocation and what structures can be damaged with this type of dislocation? So by far the most common type of hip dislocation is a posterior dislocation, where the femoral head slips out of the acetabulum posteriorly. About 90% of hip dislocations are posterior dislocations. So one of the classic injuries where this can happen is a motor vehicle accident where the knee strikes the dashboard with the thigh slightly abducted, and that drives the femoral head posteriorly, so you get a posterior hip dislocation. And then the structures that can be damaged with a posterior hip dislocation include the medial and lateral circumflex femoral arteries, both of which branch off the deep femoral artery, and they form a ring around the upper part of the femur, just below the greater trochanter. This ring supplies blood to the femoral neck, and you can imagine that if the hip is dislocated, it might tug on that arterial ring and cause a vascular injury. Posterior hip dislocations can also injure the femoral vein, and the sciatic nerve, and the head of the femur itself. Moving from the hip to the knee, let's talk about prepatellar bursitis. A bursa is a sac of tissue that contains synovial fluid, and these bursae form cushions between bones and tendons or between bones and muscles to reduce friction as our joints move. And if a bursa gets inflamed, that's called bursitis. Now, there's a bursa in front of the patella, the kneecap, and that's called the prepatellar bursa. And if you spend a lot of time kneeling, or you have other repetitive trauma to the anterior patella, this bursa can get inflamed and you'll have prepatellar bursitis. This is also called housemaid's knee because you can imagine old school cleaning women spending a lot of time on their knees scrubbing floors. Another common type of traumatic knee injury is called the unhappy triad or the terrible triad or O'Donoghue's triad. Now this is generally a sports injury that occurs due to force applied to the lateral aspect of the knee while the foot is planted, kind of like being tackled from the side. In an unhappy triad injury, there are two structures that will definitely be injured: the medial collateral ligament and the anterior cruciate ligament. Then the third part of the unhappy triad is going to be either the lateral meniscus, which is injured about 56% of the time, or the medial meniscus, which is injured about 44% of the time. Now, that seems simple enough, right? MCL, ACL, and a tear of either the lateral or medial meniscus. Unfortunately, the medical literature is an absolute jungle of contradictory, authoritative statements about which meniscus should be included in the unhappy triad. When Dr. O'Donoghue described this triad back in 1950, he included the medial meniscus. So for about 40 years, that's what doctors learned. But then around 1990, that classic triad was called into question, and some studies began to show that in fact the lateral meniscus was more commonly injured. Like I said, it's about 56% lateral to 44% medial. I'm no statistician, but that's pretty close to 50-50 if you ask me. But some experts insist that we should honor Dr. O'Donoghue's original description by using the classic unhappy triad name to describe medial meniscus injuries. And then other experts say that if the lateral meniscus tears are more common, we should redefine the unhappy triad terminology. Now, you're not likely to be asked, what are the three components of the unhappy triad of the knee? And you're going to have to choose between the medial or lateral meniscus. But they might give you a patient with an ACL and an MCL injury and then say, which other structure is most likely to be injured in this patient? And you just need to remember that the lateral meniscus injury is slightly more common. So here's how I remember it. Lateral starts with L, medial starts with M. L and M are both really close together in the alphabet, so you know it's almost 50-50. So which one comes first? L comes before M. So lateral meniscus tears are slightly more common in unhappy triad injuries than medial meniscus tears. Now while we're talking about the knee, let's talk about some tests you might do while you're examining the knee to identify torn ligaments or a torn meniscus. Now, this is really more step 2 material, so I'm going to go through these kind of quickly. The McMurray test is a test for a torn meniscus. So you flex the knee to 90 degrees, then you grab the heel and either externally rotate the tibia or internally rotate the tibia. And then while you maintain that rotation, you slowly extend the knee and flex the knee, kind of going back and forth. And you're looking for either pain or a popping sensation. If there's pain and popping during internal rotation, that's probably due to a torn lateral meniscus. If there's pain and popping during external rotation, that should make you think of a torn medial meniscus. The pain is opposite the side of the rotation. To test for a torn ACL, you're going to do the anterior drawer test. This is where you flex the patient's knee to 90 degrees and you pull the tibia anteriorly, kind of like you're pulling a drawer open. And if the tibia moves farther anteriorly than it should, that's called an anterior drawer sign or a positive anterior drawer test. There's also something called the Lockman test, which is the same thing except you put the knee at about 30 degrees of flexion instead of 90 degrees. Now beyond physical exam, the best imaging study to diagnose a torn ACL is an MRI of the knee. That has been known to pop up on step 1. So this is an MRI of a normal, intact ACL. This is a lateral view of the knee, and here's the femur, and the tibia, and the patella. And the ACL runs from the back of the femur toward the front of the tibia. So a normal ACL will show up as a prominent dark line. Now when there's an acute ACL tear, you lose that clear line. In an acute tear, there's hemorrhage and edema, so everything looks hazy and indistinct. Over time, when that acute inflammation has settled down, you might be able to make out the short, retracted ends of the ligament, like this. So again, the anterior drawer test is testing for an ACL injury. There's also a posterior drawer test, which is where you put the knee at 90 degrees again, and you push the tibia posteriorly. And if it slides too far back, that suggests a PCL tear. And then to test for an MCL or LCL tear, you extend the knee again, and you either apply a lateral force or a medial force. And you're looking to see if the joint space widens, which would suggest either an MCL tear or an LCL tear, depending on which side of the knee is unstable. So these are tests for abnormal passive abduction or abnormal passive adduction. And then one last knee pathology you might pick up on exam is a Baker cyst, which is a collection of synovial fluid in the popliteal fossa behind the knee. So this is seen in patients who have chronic knee arthritis, and it's basically an abnormal extension of the synovial space posteriorly. And finally, we come to the ankle. So let's talk briefly about ankle sprains. A sprain is basically where you stretch a ligament too far and it tears a little bit on a microscopic level, sort of a partial rupture of the ligament. Now, most ankle sprains occur laterally, like if you roll your ankle. It's very difficult to sprain your ankle immediately because the ankle just doesn't bend that way. But it's pretty easily to invert your foot and then step down and put your body weight on it, and you tear up your lateral ankle ligaments that way. There are actually 3 ligaments that hold the bones together. There's the anterior talofibular ligament, and that's the most commonly injured ligament in an ankle sprain. A student sent us a mnemonic which is to abbreviate the anterior talofibular ligament as the ATF ligament, and that stands for always tears first. So the most common ligament injured in an ankle sprain is the anterior talofibular ligament. There's also the calcaneofibular ligament, and there's the posterior talofibular ligament. And they're usually injured in that order. So the more severe the ankle sprain, the farther down you go in this list. And then on the medial side, there's the deltoid ligament holding your ankle together. And it's very rare to injure that one. Now in the study guide it asks, how should an ankle sprain be treated? And the mnemonic is RICE: rest, ice, compression, and elevation. You have the patient rest the foot by using crutches until they're able to bear weight and walk with a normal gait. They never do that, but that's the recommendation. Ice or cold packs for about 20 minutes every 2 hours for the first 48 hours. Compression with an ACE bandage, and then elevation of the foot above the level of the heart whenever possible to help reduce swelling. So propping the foot up, even if it's not above the heart, will help reduce the effect of gravity and pulling fluid into the area and causing more swelling. NSAIDs are also helpful in the first 48 hours, and then range of motion exercises like picking up marbles with the toes or tracing the alphabet in the air with a big toe or making circles with the foot. Those can all be helpful exercises. So now it's time for the end of session quiz. So pause the video and answer those questions, then we'll go through them together. First question, which muscles of the rotator cuff are responsible for each of the following actions? So the initial 15 degrees of arm abduction is the supraspinatus. External rotation of the arm is the infraspinatus and the teres minor, and internal rotation of the arm is the subscapularis. Next, which antibiotic class is known to increase the risk of tendon rupture in adults? Fluoroquinolones. And the last question, which ligaments are typically injured during an ankle sprain? Remember, it's the lateral ligaments of the ankle. Always tears first is the anterior talofibular ligament. That's the most common. But with a severe sprain, you could also see injury to the calcaneofibular ligament and the posterior talofibular ligament. And then we have just a couple of rapid-fire facts. Positive anterior drawer sign should make you think of an ACL injury, and tenderness in the anatomical snuff box should make you think of a scaphoid fracture. That's it for now. I'll see you next time. Shall we dance?
You know I'm not getting no cut.
You just want to see me. Hello, I'm Dr. Mike McInnes with a medical news flash. For years, the O'Donoghue triad, also known as the unhappy triad or the terrible triad, consisted of injury to the ACL, the MCL, and the medial meniscus.
Oh, my ACL, my MCL, my medial meniscus. Oh, it's so terrible. I'm so unhappy. Oh.
But more recent studies show that a little more than half of these so-called O'Donoghue's triad injuries involve the ACL, the MCL, and the lateral meniscus.
Oh, my ACL, my MCL, my lateral meniscus. Oh, it's so terrible. I'm so very unhappy.
And that's your medical news flash. Let's get started with the warm-up review. First question, how does adding a competitive antagonist affect the efficacy and potency of a receptor agonist? So adding a competitive antagonist will shift the dose-response curve to the right, since it takes a higher dose of the agonist to achieve the same response. So how does that affect efficacy and potency? Well, it decreases the potency, but there's no change in efficacy. Next, what is the competitive antagonist used to treat benzodiazepine overdose? That's flumazenil. And the last one, an 80-year-old man is found to have a systolic crescendo-decrescendo murmur. What's the most likely cause? The most likely cause is aortic stenosis. Even without being told the murmur's location, that description in an elderly patient is most likely going to be aortic stenosis. So let's move on to the lecture.
In this video, we're going to dive into rheumatology and talk about two important types of arthritis, osteoarthritis and rheumatoid arthritis. So let's start with osteoarthritis, which is about a 3-star topic on your test. Osteoarthritis is by far the most common type of arthritis. When patients report a history of generic arthritis, usually they're referring to osteoarthritis. Osteoarthritis is a wear and tear disease of articular cartilage. There are different degrees of articular cartilage damage, and the cartilage can be so worn that there can be bone-on-bone arthritis, and bone-on-bone grinding is very painful. This can cause something called eburnation of the bone or eburnation of the bone, which is where the abraded bone becomes hard and dense like ivory. And in addition to the wear and tear, there can be a formation of osteophytes or bone spurs. In the fingers, we give these osteophytes special names. In the PIPs, the proximal interphalangeal joints, osteophytes are referred to as Bouchard's nodes. And in the distal IP joints, the DIPs, the osteophytes are referred to as Heberden's nodes. The classical presentation of osteoarthritis in the hands would be an elderly person with really knobby interphalangeal joints in their hands. One mnemonic for remembering which name goes with which joint is to let the O in Bouchard remind you of the O in proximal. So Bouchard's nodes are found in the proximal IP joints, and Heberden's nodes are found in the distal IP joints. The joints most commonly affected in osteoarthritis are the fingers, the knees and hips, and the spine. On x-ray of the hand, you might see joint space narrowing because the cartilage is worn away, and maybe some scarring and sclerosis of the articular surfaces. Predisposing factors for osteoarthritis include age and obesity. Age because cumulative mechanical damage is just more common as you get older, because there's more time to wear down the cartilage. And obesity because more weight placed on the joints equates to more wear and tear of the cartilage. Obesity affects the weight-bearing joints like the knees, the hips, and the spine, but obesity also increases the likelihood of osteoarthritis in the hands. Joint trauma and repetitive use are additional risk factors for osteoarthritis. Examples include knee osteoarthritis in those with a history of ACL injury, ankle osteoarthritis in ballet dancers, elbow osteoarthritis in baseball pitchers, and metacarpal phalangeal joint osteoarthritis in prize fighters. The classic clinical presentation of osteoarthritis is pain in the joints after use. One classic presentation of osteoarthritis is knee pain at the end of the day after the patient has been walking around all day. The affected joint is not going to hurt first thing in the morning or with rest, as would be the case with rheumatoid arthritis. The affected joint is going to hurt after prolonged use. For example, a patient with osteoarthritis that is proficient at playing a musical instrument may find that the longer he or she plays, the more his or her hands begin to hurt. The other important conceptual thing to remember is that osteoarthritis is generally non-inflammatory and has no systemic symptoms. This is a very localized disease, unlike rheumatoid arthritis or lupus or some other systemic rheumatological disease we're going to talk about later. How do we treat osteoarthritis? Take a look at the treatment options listed in your study guide. One drug that we use quite often as the initial drug of choice is simply acetaminophen. It has very few side effects and it's very effective in treating the pain. And actually, acetaminophen is more effective if it's scheduled than if it's given as needed. This is a good clinical pearl for you. If you were to take, for instance, 2 acetaminophens on a scheduled basis 2 or 3 times a day, that would be more effective than taking 1 or 2 acetaminophen tablets whenever you need pain relief throughout the day. But you have to keep in mind the recommended maximum dose, which is 4 grams per day in adults. That's a number worth remembering as you go forward in your training. When you start getting above 4 grams per day, you run the risk of toxic doses causing liver failure and hepatitis. So what else can you use for osteoarthritis treatment? Another option is non-steroidal anti-inflammatories, such as NSAIDs and COX-2 inhibitors. In many instances, NSAIDs are used more commonly as the initial drug of choice rather than acetaminophen. Another therapeutic option is the intra-articular glucocorticoid injection to reduce local inflammation, and that can temporarily relieve a lot of the symptoms in those patients in specific joints. It's great for big joints like the knees. The downside is that the joint injections are limited to only every 4 to 6 months in order to avoid further damage to that particular joint. Another option is injecting hyaluronic acid into the joint space. This can help lubricate the joint. Hyaluronic acid is an important component of synovial fluid. If none of those options seems to be working, then you might have to resort to opioids. Opioids will simply relieve the pain. They're not going to slow disease progression. And there's certainly the risk of constipation and dependence and abuse with opioids. Additionally, placing an older patient with osteoarthritis on opioids may increase the risk of falls and fractures. So you can use opioids if necessary, but ultimately if the patient has bone-on-bone arthritis in a joint, especially the knee or hip, the definitive therapy is going to be joint replacement. If you have an obese patient, that can't walk because of severe osteoarthritis in her knees, then the patient is really going to have a hard time losing weight because it hurts too much to exercise. The limitation of physical activity increases the patient's risk for hypertension, diabetes, and cardiovascular disease. So a total knee replacement in such a patient can really help improve overall health. Now let's talk about some of these different kinds of arthritis medications in a little more detail, starting with acetaminophen. I'm sure you know that acetaminophen is Tylenol, but it's also found in a bunch of over-the-counter combinations and also in prescription combinations. So it's important to take a careful history and find out everything your patient is taking. Acetaminophen reversibly inhibits the enzyme cyclooxygenase, kind of like NSAIDs, but acetaminophen works mostly in the central nervous system. It is inactivated peripherally, which is why it's not used as an anti-inflammatory drug. It has antipyretic and analgesic effects, but it does not have any anti-inflammatory effects. So you need to separate acetaminophen in your mind from the NSAIDs. Acetaminophen can be used instead of NSAIDs in treating pain and fever in children, and often for adults too. It has fewer side effects than the NSAIDs, especially fewer GI side effects, which we'll talk about shortly. But the maximum recommended dose of acetaminophen, again, 4 grams per day in adults. So if you recommend that a patient takes 1,000 milligrams, it's about 1,000 milligrams is 2 extra strength Tylenol. If you recommend that they take those every 6 hours, then that would equate to 4 grams a day. But what about the Tylenol PM that they might take for sleep every night? It's not really a good idea to take Tylenol PM for sleep, but a lot of patients will use it. What about the NyQuil they might take when they get a cold, or the Excedrin they take for headaches every now and then? Those medications have some acetaminophen in them as well. So again, you need to know all the medications that your patient is taking. What happens with toxic doses of acetaminophen? Toxic doses of acetaminophen cause liver problems and hepatic necrosis. There's a metabolite of acetaminophen called NAPQI that depletes glutathione. Basically, under normal circumstances, when you take normal doses of acetaminophen, that NAPQI metabolite is conjugated to glutathione, it's bound to glutathione, and then it's excreted. But if you take too much acetaminophen, all the glutathione gets used up and the NAPQI is still floating around, and it starts to react with the hepatocytes. Those hepatocytes get really sick, and the AST and ALT levels in the serum start to rise as the hepatocytes are damaged. The patients can get full-blown liver failure and die if they take too much acetaminophen. So the antidote for acetaminophen overdose is N-acetylcysteine, which helps regenerate glutathione. Make sure you know that for your test. The other thing about N-acetylcysteine is that it has some other unique uses. So N-acetylcysteine is used in the treatment of acetaminophen overdose. It is also used as a mucolytic. So in a cystic fibrosis patient or an intubated patient that has some mucus plugs, you could give them inhaled N-acetylcysteine as part of their treatment to break up those mucus plugs. And then N-acetylcysteine is also occasionally used to prevent contrast nephropathy. So if you have a patient with chronic kidney disease that needs a CT scan with contrast or some other test where they need IV contrast, like a cardiac cath, and you're worried that the IV contrast is going to worsen their renal failure, you can give them some oral N-acetylcysteine before and after the IV contrast to reduce the risk of nephrotoxicity. We don't use the N-acetylcysteine regimen too often, but you might see it done occasionally. And patients really hate it because N-acetylcysteine tastes really nasty. All right, a student sent in a nice mnemonic for the uses of N-acetylcysteine, and the mnemonic is NAC. N is for nephropathy, A is for acetaminophen overdose, and C is for cystic fibrosis, but also for mucus plugs that might be present in intubated patients. All right, let's talk about NSAIDs next. So non-steroidal anti-inflammatory drugs. There was a time when steroids or glucocorticoids were the go-to anti-inflammatory drugs, but now we have the non-steroidal anti-inflammatory drugs. Some of the more common ones used in the treatment of osteoarthritis are listed in your study guide. So non-steroidals include aspirin, diclofenac, ibuprofen, which you might know better as Motrin or Advil, indomethacin, meloxicam, nabumetone, and naproxen You might know naproxen better as Aleve. NSAIDs work by inhibiting the enzyme cyclooxygenase, both COX-1 and COX-2, so they inhibit the synthesis of prostaglandins. Those prostaglandins mediate inflammation. So NSAIDs reduce fever and they reduce pain and they are anti-inflammatory. As far as the side effects, NSAIDs can cause acute renal failure because they inhibit prostaglandin synthesis, and prostaglandins are vasodilators, so NSAIDs cause some vasoconstriction, and the vasoconstriction reduces renal blood flow. NSAIDs can also cause some acute interstitial nephritis. That's another type of kidney problem. Damage is caused by a totally different mechanism there. They often cause some fluid retention, so you have to be careful about giving NSAIDs to someone that has congestive heart failure. They can rarely cause some aplastic anemia. But some of the most common side effects associated with NSAID use would be GI upset, such as gastritis and peptic ulcers, which is why you might reach for a COX-2 inhibitor instead. So let's talk about the COX-2 inhibitors. What drugs are considered COX-2 inhibitors? Celecoxib is the big one. The brand name is Celebrex. There are a couple of less commonly used drugs like meloxicam, which are relatively COX-2 selective. Meloxicam inhibits COX-2 about 10 times more than COX-1, so it's more COX-2 selective than ibuprofen, but less selective than celecoxib. That's probably not very high yield for your test, but maybe fair game. COX-2 inhibitors specifically inhibit the COX-2 form of cyclooxygenase, which is found in inflammatory cells and vascular endothelium. COX-1 is what helps maintain the gastric mucosa and generates prostaglandins to protect the gastric mucosa. So COX-2 inhibitors will cause less peptic ulcer disease than the traditional NSAIDs because they're not affecting the COX-1 in the stomach. But notice how I said less peptic ulcer disease and not zero peptic ulcer disease. COX-2 inhibitors can still cause some peptic ulcer disease and gastritis, just not nearly to the degree that traditional NSAIDs can. If you have a patient that comes in to the clinic or to the emergency room with a peptic ulcer and they're on a COX-2 inhibitor, you still need to discontinue the COX-2 inhibitor because it may be exacerbating the peptic ulcer. We use COX-2 inhibitors for osteoarthritis and rheumatoid arthritis, and also for any kind of acute inflammatory pain such as sprained ankle, muscle pain from a muscle injury, gout, or pretty much any other type of pain that you might use an NSAID for. The side effects of COX-2 inhibitors include an increased risk of thrombosis, so there's a little concern about using these in patients with heart disease, and COX-2 inhibitors are sulfa drugs, so they can cause a sulfa allergy. Let's also briefly mention aspirin. We're going to cover aspirin again in the hematology section because it inhibits platelets, but in addition to its anti-platelet effects at low doses, when you get to higher doses you can get some analgesic and anti-inflammatory effects. This is because aspirin irreversibly inhibits COX-1. So technically, aspirin is an NSAID, but traditional NSAIDs and also acetaminophen reversibly inhibit cyclooxygenase. So make sure you know that distinction. So those high doses of aspirin are going to dramatically increase the risk of gastric ulcers and bleeding. Aspirin can also cause tinnitus, it can cause hyperventilation, and it can cause some acute renal failure. So we don't really use aspirin much for arthritis. The patients might be using it on their own, so again, you have to take a careful history and educate your patients. A lot of patients seem to think that, well, aspirin is over the counter, so it must be safe, right? So I'll take a couple of aspirin every time anything hurts. Plus I'm taking the ibuprofen or naproxen or whatever the doctor recommended, and that's when patients start to get into trouble. Now we're going to talk about rheumatoid arthritis and contrast rheumatoid arthritis to osteoarthritis. Remember, osteoarthritis is very common. Rheumatoid arthritis is much, much less common, but it's still a 3 or 4 star topic for your Step 1 or Level 1 exam. A classic test question will make some comparison between rheumatoid arthritis to osteoarthritis. So they might describe the patient with arthritis and they'll give you enough clinical information to allow you to choose the correct diagnosis. Rheumatoid arthritis is a systemic autoimmune disease. It is not localized like osteoarthritis. It's systemic. It is not just a disease of one site. It's it's not just a disease of the hands, it's not just a disease of the knees, it's a whole body disease. Rheumatoid arthritis affects synovial joints. The synovium overgrows the bone and covers the surface of the cartilage, and this inflammatory synovial overgrowth is referred to as a pannus. There may be pannus formation in the metacarpal phalangeal joints, the MCPs, and in the proximal interphalangeal joints, but not the distal interphalangeal joints. So remember, for rheumatoid arthritis, think MCPs and PIPs. The distal interphalangeal joints, the DIPs, would be affected by osteoarthritis, but not rheumatoid arthritis. Also know that the inflammatory pannus can erode the articular cartilage. Take a look in your study guide at the joints that could potentially be affected by rheumatoid arthritis. Starting with the hand, there can be swan neck deformities and or boutonniere deformities. In swan neck deformity, there is PIP hyperextension with compensatory flexion of the DIP. In boutonniere deformity, there is flexion contracture of the PIP and extension of the DIP. Because this is something that students often get tripped up on, let me try to simplify it for you. A boutonniere is French for buttonhole. With a boutonniere deformity, what happens is the extensor tendon on the back of the finger splits and the PIP joint kind of pokes through like a button going through a buttonhole. So if you can remember that, you can remember that the boutonniere deformity, you have flexion of the PIP joint, and that joint is poking through that buttonhole in the extensor tendon. So flexion at the PIP and extension at the DIP, that's the boutonniere deformity. Then swan neck deformity is just the opposite. You have extension at the PIP and flexion at the DIP. At the wrist in rheumatoid arthritis, there can be radial deviation at the wrist with ulnar deviation of the digits. There might also be a deformity resulting in median nerve entrapment or carpal tunnel syndrome. At the elbow, there may be flexion contractures. At the knee, there may be synovial hypertrophy with chronic effusion and ligamentous laxity. And on a posterior aspect of the knee, a Baker cyst may form due to herniation of the inflamed synovium into the popliteal space. There can be deformities of the ankle, forefoot, subtalar joint, resulting in pain with ambulation. And finally, at the upper cervical spine, there may be atlantoaxial subluxation. So rheumatoid arthritis usually does not involve the thoracic spine, the lumbar spine, or the sacrum. These patients can also have subcutaneous rheumatoid nodules. The most common locations of rheumatoid nodules include the olecranon bursa, proximal ulna, Achilles tendon, and occiput. The deformities I just mentioned are classic for advanced rheumatoid arthritis. So rheumatoid arthritis can be fairly easy to recognize in its later stages, but in the early stages it can be much more difficult to recognize and diagnose correctly. But you need to recognize and diagnose rheumatoid arthritis as early as possible, because the longer you wait to diagnose and treat, the more irreversible joint damage there's going to be. Diagnosing and treating the disease earlier will prevent excessive joint damage. Rheumatoid arthritis is a type 3 hypersensitivity where there are autoantibodies that bind to soluble antigens in the blood and form immune complexes. And those immune complexes get deposited in the tissues and cause trouble. We'll talk about those different types of hypersensitivity in immunology, but for now just remember, rheumatoid arthritis is a type 3 hypersensitivity. Like a lot of autoimmune diseases, rheumatoid arthritis tends to be more common in women. About 80% of rheumatoid arthritis patients have a positive rheumatoid factor, which is an IgM antibody against human IgG. But the specificity for rheumatoid factor is low. Lots of patients with positive rheumatoid factor do not have rheumatoid arthritis. Additionally, about 20% of rheumatoid arthritis patients do not have a positive rheumatoid factor. There's another antibody that's much more specific called anti-citrulline protein antibody, or ACPA, or the older name you might hear is anti-CCP. So this particular antibody, anti-CCP or ACPA, is a relatively new or more specific test. So if you have a positive rheumatoid factor, you might check an ACPA to confirm the diagnosis. of rheumatoid arthritis. The classic presentation of rheumatoid arthritis is morning stiffness. Remember, we said that with osteoarthritis, you would have pain with use that is worse at the end of the day. With rheumatoid arthritis, the pain is worse first thing in the morning, and it improves with use. The description of the pain is a very important clinical clue. Patients tend to have a symmetric joint involvement with rheumatoid arthritis, and you can have systemic symptoms such as fever, fatigue, pleural effusion, and even pericarditis. Remember, we said osteoarthritis was purely a joint disease, not a systemic disease like rheumatoid arthritis. And then how do we treat rheumatoid arthritis? For acute flares or acute exacerbations, we use things like NSAIDs and COX-2 inhibitors, or sometimes a short course of steroids. But there are a lot of downsides to chronic steroid use, such as osteoporosis, Cushing syndrome, and all those things we're going to cover in endocrinology. But for long-term, day-to-day management, your treatment goal is to alter or modify the course of the illness. So we can use what we call disease-modifying anti-rheumatic drugs, or DMARDs. DMARDs include drugs like low-dose methotrexate, hydroxychloroquine, sulfasalazine, and also the TNF-alpha inhibitors. They include etanercept, infliximab, adalimumab, golimumab, and certolizumab. So that's it for the osteoarthritis and rheumatoid arthritis discussion. So go ahead and pause the video and work through the end of session quiz on your own. Then we'll go through those answers together. All right, first question. What is the classic feature of osteoarthritis? Joint pain that gets worse with use. Remember, rheumatoid arthritis gets better with use and osteoarthritis worse with use. What two antibodies are most useful in diagnosing rheumatoid arthritis? Rheumatoid factor is a great screening test, and the ACPA, or the anti-citrullonated protein antibody, is more specific, more of a confirmatory test. And then by what mechanism do NSAIDs cause renal disease? So we said there were actually two mechanisms. First off, NSAIDs block prostaglandin synthesis. And prostaglandins are necessary to optimize the blood flow to the renal vasculature. So NSAIDs lead to some constriction of renal vessels and decreased renal blood flow. And second, NSAIDs can sometimes cause acute interstitial nephritis. Let's move on to some rapid fire facts. Swollen, hard, painful finger joints would be seen in osteoarthritis. Swollen, boggy, painful finger joints would be seen in rheumatoid arthritis. And cartilage erosion with polished bone beneath, again, that's called eburnation of the bone, and that eburnation suggests osteoarthritis. All right, that's it for this video. See you next time.
Let's go over the warm-up. The question asks you to categorize all these different drugs, which is definitely high yield. So the direct cholinergic agonists include carbachol, bethanechol, and pilocarpine. Then the cholinergic antagonists are atropine, ipratropium, scopolamine, benztropine, oxybutynin, and glycopyrrolate. The indirect cholinergic agonists, or anti-acetylcholinesterases, include neostigmine, ecothiopate, donepezil, and edrophonium. So a lot of these drugs end in the ending stigmine, such as pyridostigmine and physostigmine, but those weren't listed here. So be sure you know the rest of these. Then we have some sympathomimetics. So the one that stimulates all four receptors is epinephrine. Then you drop off beta 2, and that's norepinephrine. D1 and D2 more than anything else, that's dopamine. Beta 1 and beta 2 equally is isoproterenol. Beta 2 more than beta 1 is terbutaline. And alpha 1 more than alpha 2 is phenylephrine. And then the cholinesterase regenerator is pralidoxime. The alpha blockers are the zosins, so terazosin, prazosin, and doxazosin. And then the non-selective alpha blockers include phenoxybenzamine and phentolamine. Then for the beta blockers, the non-selective beta blockers listed here are propranolol, timolol, and labetalol. And remember, labetalol is both a beta and alpha blocker, but it's a much stronger beta blocker than alpha blocker. And then the beta 1 selective beta blockers include atenolol, esmolol, and metoprolol. Now we're ready to move on to the lecture.
We've already discussed osteoarthritis and rheumatoid arthritis, and now we're going to cover several other types of arthritis, starting with gout. Gout is very high yield for step 1 and level 1. Gout is at least a 4-star topic. Gout is primarily caused by hyperuricemia, which is high uric acid levels in the blood, and then the uric acid precipitates out as monosodium urate, or MSU crystals in the joints. We call it gout, but as you should be aware, there's a more descriptive name, monosodium urate crystal deposition disease. Those monosodium urate crystals then trigger an inflammatory response, and the joint gets acutely inflamed, becoming red, hot, and painful. So if you were to stick a needle into that inflamed joint and draw out some fluid, you could see these urate crystals under the microscope. The crystals are needle-shaped, so they are long, thin, and pointy. They are also negatively birefringent. That means that if you put a special filter on the light of the microscope, a special polarizing filter that filters out most all of the light except for the light shining in one particular direction, then the crystals that are parallel to the direction of that light are going to look yellow. You can remember that the L's in the word yellow are 2 parallel lines, so these crystals look yellow when they are parallel to the direction of the polarized light. The other MSU crystal in this image is perpendicular to the polarized light, so it looks blue. The most common reason for someone to have high uric acid levels is decreased excretion of uric acid in the urine, often because they're taking a thiazide or a loop diuretic. However, high levels of serum uric acid does not always result in gout exacerbations. A relatively small number of people have a high uric acid because of increased production of uric acid. There are 3 scenarios of excess uric acid I want you to remember. Eating too many purine-rich foods such as anchovies, sardines, kidneys, liver, or sweetbreads. If you don't know what sweetbreads are, sweetbreads is a name given to dietary thymus and pancreas. The second scenario is Lesch-Nyhan syndrome, and the third scenario is leukemia or lymphoma, where the treatment causes increased cell turnover and tumor lysis, and that lysis of cells can induce excess uric acid. Clinically, gout presents with asymmetric joint inflammation. So instead of several inflamed joints in both hands, like with rheumatoid arthritis, with gout, you may have one inflamed joint here, one inflamed joint there, and so the pattern of joint involvement is asymmetrical. And it's usually just one joint at a time, which is different from both osteoarthritis and rheumatoid arthritis. If you have inflammation in a bunch of joints, such as in rheumatoid arthritis, we call that polyarthritis. If it's just one joint at a time, such as in gout, it's monoarticular arthritis. Or if we're talking about a few joints, a small number, but more than one, that's oligoarthritis. But gout is usually monoarticular, one joint at a time. The inflamed joints in this image are swollen, red, and exquisitely painful. And the most classic joint involved is the first metatarsophalangeal joint, the big toe, and the name for this inflammation in the first MTP is podagra. That just means there's an acute flare of gout in the first MTP joint. You can also see tophi, which are masses of urate crystals either on tendons or on the ear or on the olecranon bursa. Tophi are not inflamed or tender, they're just masses of urate crystals under the skin. Gout tends to be cyclical, so it flares up, then it cools down. Patients with gout don't have that red, hot, painful toe all the time. It just comes and goes. Some patients have flares with great frequency, and some have very rare flares. If they have an attack of gout once a year or less, there probably is not a need for that patient to be on acute gout drugs. If they were having attacks more than once or twice a year, they're probably going to need an anti-gout drug treatment regimen. So what kinds of things precipitate an acute attack of gout or flares of gouty arthritis? Flares can result from dietary excess or after excessive alcohol consumption. The mechanism of alcohol-induced gout exacerbation is worth knowing. Alcohol metabolites compete for the same excretion sites as uric acid in the kidney. The kidney has to choose between excreting uric acid or excreting the metabolites of alcohol. And like I said, most patients with gout have elevated serum levels of uric acid, but the serum uric acid level does not predict gout. You can have acute gout without elevated uric acid, and you can have elevated uric acid without having gout. The serum uric acid level is a useful clinical clue, and it may influence your choice of medication for treatment, but it's not diagnostic by any means. Let's talk about the treatment of gout, which is also high yield for your test. We treat acute gout and chronic gout with different drugs. Let's talk about the treatment of acute gout flares first. One of the classic acute gout drugs is colchicine. But here's where I'm going to teach you what you need to know for the test, then I'm going to teach you what the real-life application. So for the test, colchicine is a classic drug used for acute gout exacerbations. You might recall colchicine as one of the drugs that inhibits microtubules. Colchicine works by binding and stabilizing tubulin to inhibit the polymerization of tubulin, so it impairs leukocyte chemotaxis. The inflammatory cells can't get to where they need to go, so there is less inflammation. Colchicine is known for its GI side effects, particularly diarrhea. We used to give a dose of colchicine every hour until the patient either got better, developed severe diarrhea, or reached the maximum dose of the medication. Now the current recommendation is that if you're going to use colchicine, you just give 2 low doses, and that seems to work about as well as the old scorched earth regimen. Colchicine has a fairly low therapeutic index, which means there's not much difference between the therapeutic dose and the toxic dose. It doesn't take much colchicine to cause toxicity because a lot of your body cells need working microtubules. If you inhibit those microtubules, you can get pretty sick, and excess colchicine ingestion can result in death. So for that reason, NSAIDs instead of colchicine are going to be the treatment of choice for acute gout, at least on your test. You may use any NSAID, but indomethacin is a classic NSAID used for gout, and indomethacin is probably the best answer on your test for the treatment of acute gout. But in the real world, you might use NSAIDs, but most doctors I know just give a short course of steroids instead. You give oral steroids for 4 or 5 days, and these patients feel much better very quickly. So that's the treatment of acute gout flares. What about treating chronic gout? So the patient had an acute flare, and you got the flare under control with steroids or indomethacin, and now you need to control the uric acid level so that you can prevent future attacks of gout. And there are a couple of different strategies to prevent acute flare-ups of gout. One strategy is to increase renal excretion of uric acid using probenecid. Probenecid works by inhibiting reabsorption of uric acid in the proximal convoluted tubule, which means that more of the uric acid is going to stay in the urine and get excreted. As a side note, probenecid also inhibits secretion of penicillin. So in World War II, when penicillin was in short supply, they were able to conserve penicillin by giving probenecid along with lower doses of penicillin. The other strategy for lowering uric acid levels chronically is to reduce uric acid synthesis. The main drug that does this is allopurinol. Allopurinol inhibits the enzyme xanthine oxidase. Xanthine oxidase is responsible for converting xanthine to uric acid. So if you aren't making as much uric acid, you might have less gout. And there's another much newer drug called febuxostat that also works by inhibiting xanthine oxidase. So these 2 drugs, allopurinol and febuxostat, are particularly effective in patients with gout due to high uric acid levels. So to recap, for acute gout, for testing purposes, you're going to start with an NSAID, usually indomethacin, and then colchicine would be a second-line drug, but in the real world, you would use steroids such as prednisone first line. And then for chronic gout, allopurinol is used much more commonly than probenecid. Maybe if they give you a clinical scenario in which they specifically tell you that the patient has very low uric acid levels in their urine, so they're under-excreting the uric acid, maybe then they want you to pick probenecid. Also, low-dose colchicine can be used for the management of chronic gout, but for the most part, allopurinol is the go-to drug for managing chronic gout. So let's talk about pseudogout, which is obviously very similar to gout. It's just a different crystal that you're dealing with. Instead of the monosodium urate crystals, you're dealing with calcium pyrophosphate crystals. You might use the P in pyrophosphate and the P in pseudogout to keep them straight, if that helps. And then the official name is calcium pyrophosphate deposition disease. In pseudogout, instead of needle-shaped crystals, there are rhomboid-shaped crystals, and they are weakly positively birefringent, which is another P word. Pseudogout, pyrophosphate, positively birefringent. Remember, the urate crystals were negatively birefringent, so they were yellow when they were parallel in the polarized light. But the rhomboidal calcium pyrophosphate crystals seen in pseudogout are weakly positively birefringent and are blue when they are parallel to the polarized light. but when they are perpendicular to polarized light, they look yellow. Pseudogout usually affects the large joints, classically the knee, and it affects older patients over 50 years old, often over 60 or 70 years of age. Then treatment is basically the same as gout as well, steroids or NSAIDs or colchicine. Then one other thing I want to mention with pseudogout is something called chondrocalcinosis. Chondro means cartilage and calcinosis means calcification. This is calcification of the articular cartilage. If you see an x-ray of the knee with these thin lines of calcification along the cartilage, especially in the meniscus, that suggests pseudogout. Now let's talk about the seronegative spondyloarthropathies, which is a group of disorders that are associated with arthritis, especially arthritis of the spine, which is where the word spondylo comes in. Spondylos is a Greek word for spine. But the rheumatoid factor in these disorders is negative. With rheumatoid arthritis, you have that positive rheumatoid factor, but not with the seronegative spondyloarthropathies. And these disorders have a strong association with HLA-B27. And the mnemonic for these HLA-B27 associated diseases is PAIR, P-A-I-R. P is for psoriatic arthritis, A is for ankylosing spondylitis, I is for inflammatory bowel disease with the associated arthritis, and R is for reactive arthritis, and the old name is Reiter's syndrome. All right, let's talk about psoriatic arthritis first. I'm not going to say a whole lot about psoriatic arthritis. It's a form of inflammatory arthritis associated with psoriasis. Psoriasis is a disorder of the skin that is characterized by skin lesions that are scaly plaques or papules that are classically described as having a silver scale. The arthritis is often asymmetric, just like the psoriasis is asymmetric and patchy. But psoriatic arthritis can also be very symmetrical and can look an awful lot like rheumatoid arthritis. Psoriatic arthritis often affects the fingers, especially the DIP joints. It can also affect the spine and sacroiliac joints. Remember that rheumatoid arthritis affects the MCP joints and PIP joints. You can have dactylitis, and that is inflammation and swelling of the fingers, which is occasionally referred to as sausage fingers. And x-rays of the fingers may show bony erosions that we call pencil and cup deformity. Only about a third of psoriasis patients will actually have the psoriatic arthritis. So you can have psoriasis without any arthritis, or you can have psoriatic arthritis without any psoriasis, although that's less common. You can have both psoriasis on the skin and the arthritis. The next one is ankylosing spondylitis. Ankylosing spondylitis is a chronic inflammatory disease of the spine and in the sacroiliac joints. Spondylitis means inflammation of the spine, but make sure you remember sacroiliac joints, because anytime you see sacroiliitis or inflammation of the sacroiliac joint on your chest, one of the first things you should think about is ankylosing spondylitis. If there is chronic inflammation of the spine, this can result in ankylosis, where the joint starts to fuse. You can have fusion of the SI joints or fusion between the discs, or sometimes fusion in the facet joints. You can actually see what we call a bamboo spine on x-ray. So instead of the normal light vertebrae and then dark intervertebral discs, you can see calcification and mineralization along the intervertebral discs. The spine in cases of ankylosing spondylitis looks like a stick of bamboo. A bamboo-like spine is obviously going to limit spine mobility quite a bit, which is a classic feature of advanced ankylosing spondylitis, reduced spine mobility. And the stiffness of the spine and sacroiliac joints tends to improve with exercise. This is typically a disease that begins in young adulthood in the 20s or 30s, and a lot of these individuals will get up early in the morning and go work out or go for a 5-mile run, because that helps reduce the stiffness so that they can function during the day. Ankylosing spondylitis is associated with uveitis, inflammation of the vascular layer of the eye, and there's an increased risk of aortic regurgitation and conduction abnormalities and cardiovascular disease in general, such as peripheral vascular disease and even congestive heart failure. Then there is the I in the PAIR mnemonic, which stands for IBD, inflammatory bowel disease, and they're going to be covered elsewhere in the lecture, but ulcerative colitis and Crohn's disease can both have an arthritic component, a spondylitis or a polyarthritis. Then there's reactive arthritis. This is a form of arthritis that typically comes on following certain infections, typically either chlamydia or gastrointestinal infections, classically Shigella, but also things like Salmonella, Yersinia, Campylobacter, and maybe Clostridium. So the patient had the infection, and then later they got a reaction to that infection, so it's a reactive arthritis. And the classic triad of reactive arthritis is conjunctivitis, or maybe uveitis. The second component of the triad would be urethritis, and the third component would be arthritis. The classic mnemonic is can't see, can't pee, can't climb a tree. Again, those 4 diseases, psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease associated with either spondylitis or polyarthritis. And then reactive arthritis are the seronegative spondyloarthropathies, and these are more common in patients with HLA-B27, especially men with HLA-B27. Then to treat these, in general we start with NSAIDs or possibly some steroids acutely, and sometimes you use those disease-modifying anti-rheumatic drugs or DMARDs. And the TNF-alpha inhibitor drugs are very important in treating those seronegative spondyloarthropathies. So let's talk about those TNF-alpha inhibitors for just a moment. TNF-alpha is a cytokine that induces the immune system, and the TNF-alpha inhibitors are drugs that bind to TNF-alpha and prevent it from activating the immune system. These drugs do suppress the immune system some. There are several available TNF-alpha inhibitors, although there are more being developed all the time. There's etanercept, infliximab, adalimumab, golimumab, and certolizumab. You can tell by the suffix MAB that the last 4 are monoclonal antibodies. They're antibodies against TNF-alpha. Etanercept is a little bit different. It's actually a recombinant TNF receptor that gets infused, so it acts as a decoy to bind up all the TNF in the body. Each of these drugs has a very specific FDA-approved use, but they all get used off-label as well. You don't need to memorize the specific indications for each drug. Just know that in general, they're used for rheumatoid arthritis and for these seronegative spondyloarthropathies. Then the other important point about these drugs is that since they are inhibiting the immune system, they carry an increased risk of infection, especially reactivation of latent tuberculosis. So we check a PPD, a TB skin test, before starting any of these drugs. And let's talk briefly about a type of arthritis called juvenile idiopathic arthritis. It used to be called juvenile rheumatoid arthritis, or JRA, but they've changed the name to JIA, juvenile idiopathic arthritis. JIA is a disease of children characterized by onset usually before age 10. The classic feature is persistent joint swelling caused by thickening of the synovium and accumulation of synovial fluid. There are 3 types of JIA. There's polyarticular JIA, which is characterized by severe symmetrical arthritis, and the inflammation of the fingers is called dactylitis. Then there's pauciarticular JIA. Pauci means few, so instead of a bunch of joints being involved, this just involves a few joints, typically the large joints, but it almost never starts in the hips. And about 20 to 25% of those kids also get uveitis. And the third type of JIA is called systemic onset JIA, and the old name is Still's disease. These patients can have arthritis, but they often have systemic symptoms such as fever, rash, elevated white count, anemia, hepatosplenomegaly, and lymphadenopathy. If they have all of these systemic symptoms, but not much in the way of obvious arthritis, JIA can look a lot like leukemia or lymphoma. Then one last important form of arthritis is infectious arthritis or septic arthritis. Septic arthritis can be caused by lots of different bugs, but the most common ones are Staph aureus, Streptococcus, and Neisseria gonorrhea. Gonococcal arthritis is an STD that presents as a polyarticular migratory arthritis with an asymmetrical pattern. The classic test scenario is a young sexually active person that has a swollen, painful knee. That's more likely to be Neisseria gonorrhea in that clinical scenario than anything else. Gonorrhea can cause synovitis, tenosynovitis, and pustules on the skin. How do we diagnose septic arthritis? You need to do an arthrocentesis. If you have any suspicion of septic arthritis, you have to stick a needle into the joint and aspirate some fluid. The fluid is basically pus, and when you look at it under the microscope, you will see a ton of white blood cells, and you might see some bacteria as well. And the reason you have to aspirate the joint is that septic arthritis can be really destructive, and if you find septic arthritis, you need to start IV antibiotics right away and get an orthopedic surgeon to clean out the infection. So that's it for joint diseases. Now it's time for the end of session quiz. So go through those questions on your own, and then we'll answer those questions together. All right, first question. What medications are used in the treatment of acute gout exacerbation? NSAIDs like indomethacin, or even run-of-the-mill ibuprofen or naproxen. You can use colchicine or you can use steroids. What drugs can be used in the treatment of chronic gout? Allopurinol most often, probenecid occasionally, or you can use colchicine or NSAIDs long-term if you choose. A sexually active 19-year-old man presents with pink eye, arthritis of the right knee, and dysuria. What is the most likely diagnosis? So a sexually active patient with acute arthritis of the knee and possibly some urethritis make you think about gonorrhea and gonococcal arthritis. And this patient also has conjunctivitis, pink eye. So this is probably a reactive arthritis. Can't see, can't pee, can't climb a tree. Remember the mnemonic in the triad associated with reactive arthritis. So that's it for this quiz. Now look at all the rapid fire facts. Go through those and then we'll cover those together. A swollen, red, acutely painful great toe joint would be podagra, seen in gout. Positively birefringent rhomboid-shaped crystals would indicate pseudogout. Negatively birefringent needle-shaped crystals would indicate gout. Bamboo spine on X-ray is a buzzword for ankylosing spondylitis. HLA-B27 is seen mainly in the seronegative spondyloarthropathies where there's a negative rheumatoid factor. And those were psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease arthritis, and reactive arthritis. Pencil and cup deformity on X-ray of the finger is psoriatic arthritis. All right, so that's it for this video. See you next time.
It's time for another warm-up. Let's get going. What are the clinical uses for each of the following anti-muscarinic drugs? The first one we have here is ipratropium. So this is used to treat COPD and asthma. It's often used in combination with albuterol, sometimes on its own. Next we have atropine, homatropine, and tropicamide. So these are used to dilate the pupils and they cause mydriasis. So they're also going to cause psychoplegia as well, or paralysis of the auxiliary eye muscles. Next we have benztropine. This is used to treat Parkinson's disease. Scopolamine, so this is a patch often used you put behind the ear, used for motion sickness. It can also be used for end-of-life care to reduce secretions. So a terminally ill patient who is constantly choking on their own oral secretions, you can use this. Next, which receptors use a GS protein? So that's going to be a beta-1, beta-2, vasopressin 2, histamine 2, and dopamine 1. Right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to look at a bunch of disorders that may affect the joints somewhat, but largely these affect other parts of the body, and in some cases the entire body. So these are systemic rheumatologic disorders. We'll start with systemic lupus erythematosus, or SLE. The vast majority of lupus patients are young to middle-aged women, and lupus is more common in black women. Lupus is a disease with a zillion possible presentations. Patients can have nonspecific systemic symptoms such as fatigue, weight loss, fever. Patients can have lymphadenopathy in the neck, the axilla, or the groin. And they can have some splenomegaly as well. Patients can acquire a type of endocarditis called Liebman-Sachs endocarditis, where they have sterile vegetations on their heart valves. So these look like the vegetations of bacterial endocarditis, but nothing grows on culture. They're sterile vegetations. So it may help you to remember that patients with SLE can get LSE, or Liebman-Sachs endocarditis. Lupus can also cause Raynaud phenomenon, where you have vasospasm in the fingers due to exposure to cold temperature. We'll discuss Raynaud phenomenon in cardiology as well. So lupus can cause a lot of very different clinical presentations. One person's lupus can look completely different from someone else's lupus. Let's turn to the study guide to look at the diagnostic criteria. There are 11 diagnostic criteria for lupus, and you have to have at least 4 out of 11 to make the diagnosis. A lupus patient does not have to have all 4 at the same time, but at least 4 at some point during the course of the disease. We've grouped these criteria into skin disorders, inflammatory disorders, and then various organ system disorders. What are the skin findings associated with lupus? There could be a malar rash, described as a butterfly rash on the cheeks. There could be a discoid rash, which are discrete raised erythematous lesions with some scaling, usually on the face or scalp or ears. And they can cause atrophic scarring. So this is what the music artist Seal has on his face, scars left over from discoid lupus. That fact may help you remember what the lesions look like. You can have photosensitivity. You can have painless oral ulcers. Very important, these aren't painful aphthous ulcers. These are painless oral ulcers. So make sure you recognize the distinction. For the inflammatory conditions associated with lupus, you can have arthritis, which is a non-erosive, non-destructive arthritis at least 2 joints. Osteoarthritis would be an example of a destructive, erosive arthritis, but this is a non-erosive arthritis. You need at least 2 joints with non-erosive arthritis in diagnosing lupus. Serositis is inflammation of the serosa, such as pleuritis or pericarditis. And then positive ANA is one of the inflammatory criteria. ANA is pretty nonspecific though. And although ANA is one of the diagnostic criteria, the patient doesn't have to have a positive ANA to make the diagnosis of lupus. And more importantly, just because a patient has a positive ANA doesn't mean that the patient definitely has lupus either. But it is one of the criteria. And we're talking about significantly positive ANA, like 1 to 160 or 1 to 320. Patients sometimes want to get all excited about an ANA titer of 1 to 4 or 1 to 8, but that's very common and very nonspecific. Then the last group of criteria are the organ system disorders. Proteinuria or cellular cast would indicate renal disease or lupus nephritis. We'll come back to lupus-associated renal disease again in a moment. Neurologic disorders include seizures and psychosis. Hematologic disorders include hemolytic anemia, leukopenia, lymphopenia, and thrombocytopenia. And then immune disorders, as indicated by autoimmune disease, such as positive anti-phospholipid antibodies, anti-double-stranded DNA antibodies, anti-Smith antibodies, or a false positive VDRL. So let's backtrack for a second and talk about lupus nephritis a little bit more. Renal failure from progressive lupus nephritis is one of the leading causes of death in lupus patients. In lupus nephritis, you can see wire loop lesions in the kidney histologically and deposition of immune complexes. So it might help you to remember the phrase wire lupus. So lupus has wire loops or wire lupus, which is basically thickening of the capillary walls. What lab tests do we use to diagnose lupus? We mentioned ANA or anti-nuclear antibodies. ANA is sensitive but not very specific for lupus. It's a decent screening test for lupus. Almost all patients with lupus have a positive ANA, but again, it's not necessary to make the diagnosis. If the ANA is negative, you're much less likely to have lupus. If it's positive, it could be lupus or it could be something else. So what else has a positive ANA? Sjogren's syndrome, scleroderma, polymyositis, dermatomyositis, rheumatoid arthritis, juvenile idiopathic arthritis, and mixed connective tissue disease can all be associated with a positive ANA. So again, ANA is sensitive but not specific. We mentioned anti-double-stranded DNA antibody. That's much more specific for lupus, and especially for the renal disease associated with lupus. There are also anti-Smith antibodies, which are also very specific for lupus. Anti-histone antibodies are associated with drug-induced lupus in addition to systemic lupus. You can have anti-histone antibodies with regular lupus that's not drug-induced, but classically we think of it as drug-induced lupus. So for the purposes of your exam, you can think of anti-histone antibodies as being a clue for drug-induced lupus. Then what are the drugs associated with drug-induced lupus? The mnemonic is SHIP, S-H-I-P-P, for sulfonamides, hydralazine, isoniazid, phenytoin, and procainamide. A couple more labs that you might check in a lupus patient. There are anti-phospholipid antibodies, which cross-react with the cardiolipin used in lab tests. So you'll also hear these called anti-cardiolipin antibodies. You can have positive anti-phospholipid antibodies or positive anti-cardiolipin antibodies without having lupus, but they are commonly associated with lupus. And these antibodies cause coagulation disorders, resulting in hypercoagulability. Then the other immunologic marker you should know is decreased serum C3 and C4. Lupus can result in low levels of complement, causing some immunodeficiency and increasing the risk of severe infections. One last thing to mention briefly about lupus is the treatment. Steroids are commonly used, NSAIDs are commonly used, hydroxychloroquine is a drug that you might want to know, often used to treat lupus. And for advanced lupus, especially if there's some lupus nephritis, cyclophosphamide can be useful. So glucocorticoids, NSAIDs, hydroxychloroquine, and cyclophosphamide are the drugs I want you to know that are commonly used to treat lupus. Let's talk about scleroderma next. It's also known as progressive systemic sclerosis. Scleroderma is a disease where you have fibrosis and excess collagen deposition throughout the body, not just the skin, but throughout the body. It's not really an inflammatory disease at all, it's a bulking disease. Because you have so much fibrosis and collagen that's going to interfere with the normal function of a lot of different tissues. So you get sclerosis and scarring of the skin, so that skin becomes tight and sometimes shiny with no wrinkles. The tightening of the skin on the fingers can cause contraction of the fingers and sometimes ulcers on the fingers. So these patients might have trouble extending their fingers and possibly difficulty gripping their fingers also. Then beyond the skin, you can involve lots of other tissues. There are two types of scleroderma that I want you to know for your test: diffuse scleroderma and crest scleroderma. Diffuse scleroderma is characterized by diffuse widespread sclerosis, which progresses rapidly and tends to involve the visceral organs fairly early. And diffuse scleroderma is associated with antibodies against DNA topoisomerase 1. Another name for those antibodies is anti-SCL70 antibodies. SCL is for scleroderma. You need to remember both of those names: anti-DNA topoisomerase 1 antibodies and anti-SCL70. And then the second major form of scleroderma is crest syndrome, which is a different variant of scleroderma. C in crest is for calcinosis or subepithelial calcium deposits. R is for Raynaud phenomenon. E is for esophageal dysmotility. S is for sclerodactyly or scarring of the fingers, and T is for telangiectasias. Again, calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. With crest syndrome, there is limited skin involvement. It can affect the fingers and face in terms of skin involvement, but you also have these other problems we just mentioned. The crest form is generally more benign, there's less visceral involvement, and it progresses less rapidly. And crest syndrome is associated with anti-centromere antibodies. So remember C for centromere and C for crest scleroderma. Let's move on to Sjogren's syndrome. First, the basics. Sjogren's syndrome consists of a triad of dry eyes called xerophthalmia, dry mouth called xerostomia, and disease-defining antibodies including anti-Rho, also called anti-SSA, and or anti-LAW, also called anti-SSB. There are other autoimmune diseases that have the sickest symptoms of xerophthalmia, also known as keratoconjunctivitis sicca, and xerostomia, but only patients with Sjogren's syndrome have the disease-defining antibodies I just mentioned. Additionally, the majority of Sjogren patients also have arthralgias or arthritis as an extraglandular manifestation. All right, now let's discuss Sjogren's syndrome in a little more detail. The problem in Sjogren's syndrome is autoimmunity. Most patients with Sjogren are women between the ages of 50 and 60. The immune system attacks the exocrine glands, particularly the lacrimal and salivary glands, resulting in a lymphocytic infiltration of B and T lymphocytes. As a result of the lacrimal gland infiltration, patients have dry eyes, or again, the dry eyes referred to as xerophthalmia, possibly conjunctivitis, and possibly a sensation of sand in the eyes. As a result of the salivary gland infiltration, patients often have bilateral parotid enlargement and an excessively dry mouth that may cause dysphagia, or an inability to speak more than a few sentences, or an increase in dental caries is a huge clinical clue. Other exocrine glands may be targeted by the disease, resulting in nasal dryness, dry throat, known as xerotrachea, and consequently chronic bronchitis. Additionally, vaginal dryness and dyspareunia and/or reflux esophagitis. To help you remember the constellation of symptoms, dry eyes, dry mouth, and usually arthritis associated with Sjogren's syndrome, you might use the mnemonic for Sjogren, which is can't see, can't spit, can't climb up shit. So maybe that's helpful. A few other things to know about Sjogren's syndrome. The definitive way to diagnose Sjogren's syndrome is by biopsy of the lip to examine the minor salivary glands found there. I mentioned the disease is associated with an excessive lymphoid infiltrate. Associated with this is an increased risk of B-cell lymphoma. I mentioned arthralgias and arthritis as possible extraglandular manifestations. There are other possible extraglandular manifestations associated with Sjogren syndrome, such as Raynaud phenomenon, but those are beyond the scope of your exam. All right, let's go over a few muscle disorders next, starting with muscular dystrophy. There's Duchenne muscular dystrophy and Becker muscular dystrophy. Duchenne muscular dystrophy is caused by an X-linked frameshift mutation that causes a deletion of the dystrophin gene, leading to accelerated muscle breakdown. The dystrophin gene is the longest known human gene, which makes it kind of a setup for spontaneous mutations. The dystrophin protein helps to anchor muscle fibers, particularly in the skeletal and cardiac muscle. Without dystrophin, you have accelerated muscle breakdown, and that causes elevated creatine kinase, abbreviated CK. What is CK a marker for? It's a marker for muscle breakdown. As muscle cells become inflamed or injured, they die and they spill their contents, including creatine kinase. Duchenne muscular dystrophy presents very early in life, before age 5, starting with weakness in the pelvic girdle muscles, which eventually progresses superiorly. Kids with Duchenne muscular dystrophy get pseudohypertrophy of the calf muscles due to fibrofatty replacement in those tissues. That's why it's called pseudohypertrophy. It's not true muscle hypertrophy. The calves look bigger, but it's replacement of muscle with the fibrofatty tissue that's making the muscle look bigger. Another classic sign of Duchenne muscular dystrophy is called Gower's maneuver. These kids can't stand up from a squatting position because their proximal leg muscles are weak. So they get up off the floor by using their arms, and they walk their hands from the floor to their feet and then up their legs to stand up. You can find a lot of different YouTube videos that demonstrate Gower's maneuver if you've never seen it. Then Becker muscular dystrophy is due to an in-frame deletion that results in a mutated dystrophin gene instead of the deleted dystrophin gene that we saw with Duchenne muscular dystrophy. So Becker is less severe than Duchenne, and there's later onset in adolescence or early adulthood instead of before age 5. For example, patients with Duchenne muscular dystrophy are typically in a wheelchair by age 12, while patients with Becker muscular dystrophy are able to walk beyond age 15. Next, we're going to talk about polymyalgia rheumatica. And since it's called polymyalgia, you would think this is a muscle disease, but it's really not. It's a type of joint pain. There's joint pain and stiffness in the proximal joints, the hips, the shoulder girdle, and maybe the neck. And then polymyalgia rheumatica is a systemic disease, so it's often associated with malaise, weight loss, and fever. But in polymyalgia rheumatica, there is no muscle weakness. So that can help you distinguish polymyalgia rheumatica from polymyositis. The average age of onset of polymyalgia rheumatica is age 70, and it's 2 or 3 times more common in women. So if they give you a little old lady with proximal joint pain and stiffness, think about polymyalgia rheumatica. And it's sometimes associated with temporal arteritis, also called giant cell arteritis. Temporal arteritis is covered in the cardiovascular section. And we'll talk about different types of vasculitides in the cardiovascular section as well. With polymyalgia rheumatica, you have elevated ESR and normal creatine kinase. Again, this is not a muscle problem, so creatine kinase is normal, indicating no muscle disease. The treatment is steroids such as prednisone. You give them just a small amount of prednisone and they miraculously feel much better. Now, sometimes people will get polymyalgia mixed up with polymyositis. But polymyositis is really a disease of muscles. It's a muscle inflammation. Myo is muscle and itis is inflammation. So polymyositis is an inflammatory muscle disease. Muscle diseases typically affect the proximal muscles more severely because those are your big muscles, and more muscle means more opportunity for pathology and muscle disease. So that's one of the hallmarks of muscle disease, proximal muscle weakness. Distal weakness tends to be caused by neurologic disease because the neurons have to travel a longer way from the brain to the distal parts of the limbs. So they're more susceptible to injury because of that long distance. So proximal muscle weakness is often due to a muscle problem, and distal weakness is often due to a neurologic problem. With polymyositis, there is a CD8 positive cytotoxic T cell induced injury to the muscle fibers, often involving the shoulders and the pelvic girdle muscles, again, proximal muscles. To make the diagnosis, you might use a muscle biopsy to look for evidence of inflammation. Labs will show elevated CK because of muscle inflammation and muscle breakdown. So with polymyalgia rheumatica, we said the CK was normal, but with polymyositis, the CK is elevated. Another useful lab marker is elevated aldolase, which is another enzyme released from inflamed muscle. And in polymyositis, you have positive ANA and positive anti-Jo1 antibodies. Dermatomyositis is similar to polymyositis, but in addition to the muscle inflammation, you also have a skin involvement. There are several interesting skin manifestations associated with dermatomyositis, including a malar rash, like we saw with lupus, purple heliotrope rash on the eyelids, Gottron's papules, which are reddish, scaly papules on the knuckles and maybe on the elbows and the knees. There might be something called a shawl sign, where the rash is over the shoulders like a shawl draped over the shoulders, or a V sign, where it's in the anterior chest in a V shape, like a V-necked shirt. There might be something called mechanic's hands, which is where the fingers are rough and cracked. Here you see those changes on the foot, and the skin can even look dirty sometimes, like you've been working on a car. So if you see one of these plus muscle weakness, think about dermatomyositis. There may be a little mild muscle soreness, but it's primarily muscle weakness. Polymyositis and dermatomyositis also carry an increased risk of malignancy. This is a little controversial, but about 15% of patients with dermatomyositis will either be diagnosed with a malignancy at the same time or will be found to have a malignancy down the road. Again, the instances of malignancy are 15% for dermatomyositis and about 10% for polymyositis. Then one last disease to cover is fibromyalgia. Fibromyalgia is a disease of increased sensitivity to pain, sort of resetting the pain threshold, so it causes excess muscle tenderness in 11 out of 18 particular sites. So there are 18 specific areas called trigger points, 9 on each side of the body. The classic way to diagnose fibromyalgia is to palpate these trigger points, where the patient might be tender with a specified amount of pressure, and if they are tender in at least 11 of those 18 sites, you can make the diagnosis of fibromyalgia. In addition to muscle tenderness, patients may also have chronic generalized pain, fatigue, sleep disturbances, headache, cognitive difficulty, and or mood disturbances as comorbidities. And at least 30% of these patients also have depression or anxiety. Then for the pharmacological treatment of fibromyalgia, there are 2 drugs that the FDA has approved specifically for fibromyalgia. There's pregabalin, which is an anticonvulsant mainly used for neuropathic pain, and there's milnacipran, which is an SNRI, a serotonin norepinephrine reuptake inhibitor. But outside of the official FDA-approved treatments, some of the older treatments include amitriptyline, a tricyclic antidepressant, low-dose analgesics such as acetaminophen or NSAIDs, and fluoxetine or Prozac. I try to avoid opioids because patients with fibromyalgia have chronic pain, and once you start them on narcotics, typically they're going to be on them forever and develop tolerance, and then they keep coming back for more opioids and wanting more and more. So narcotic pain meds are just not the best choice for treating fibromyalgia. And then non-pharmacological treatment is very important, including reassurance that they don't have lupus or some type of crippling arthritis. Educate them about the diagnosis of fibromyalgia. Stretching exercises are very important. Sleep is a huge problem for patients with fibromyalgia. They're always tired, they don't sleep well, and the lack of sleep makes them hurt. And when they hurt, they don't sleep well. Sometimes we'll use sedating antidepressants such as trazodone to help them sleep, and trazodone may also help their depression. And then relaxation techniques and stress reduction are important as well. So that's it for systemic rheumatologic diseases and muscle disorders. Now you're ready for the end of session quiz and the rapid fire facts. So work through those and then we'll go through those answers together. First question, a patient presents with photosensitivity, arthritis, hemolytic anemia, and recurrent oral ulcers. What's the most likely diagnosis? So this constellation of symptoms is most likely lupus. What drugs are known for causing drug-induced lupus? Remember the mnemonic SHIP, S-H-I-P-P. Sulfonamides, hydralazine, isoniazid, phenytoin, and procainamide. What are some of the characteristics of polymyositis that distinguish it from polymyalgia rheumatica? In polymyositis, there is muscle weakness as well as elevated CK, aldolase, ANA, and anti-Jo1. In polymyalgia rheumatica, there is joint pain but no muscle pain or weakness. And since there is no muscle inflammation, CK and aldolase will be normal. And then there's a list of rapid fire facts. Let's go through those. Anti-Smith and anti-double-stranded DNA antibodies are suggestive of lupus. Anti-histone antibodies are seen in drug-induced lupus. Anti-centromere antibodies are seen in crest scleroderma. Anti-topoisomerase antibodies are seen in diffuse systemic scleroderma. Anti-Jo antibodies are seen in polymyositis. Anti-Rho antibodies, also known as anti-SSA antibodies, are seen in Sjogren's syndrome. The triad of arthritis, dry mouth, and dry eyes characterize Sjogren's syndrome. All right, that's it for this video. See you next time.
Let's take a look at the answers to the warm-up review. First question, how does a drug's dose-response curve change with the addition of a competitive antagonist as compared to the addition of a non-competitive antagonist? So a competitive antagonist shifts the dose-response curve to the right, which decreases the potency. A non-competitive antagonist will shift the curve down, so efficacy is decreased but potency doesn't change. Next, what are the clinical uses for each of the following sympathomimetics? So dopamine is used to treat shock. Clonidine is used to treat hypertension. It's a sympathomimetic in that it is an alpha-2 agonist, although this actually decreases norepinephrine release. Amphetamines have lots of different uses and can be used to treat ADHD. They can be used for weight loss and obesity. And they're also used for narcolepsy. Terbutaline is used for asthma patients. It can also be given for tocolysis to stop uterine contractions. And then epinephrine is used primarily for anaphylactic shock. And that's it for this warm-up. Let's move on to the lecture.
Hello everyone, and welcome to the Step 1 Derm lectures. These next two lectures will start with some derm anatomy, maybe a little physiology, and then we'll move into pathology. Well, really a list of conditions, and the lecture may feel a little choppy, but don't worry about it. We're going to hit the high-yield things and then move on. Okay, so diving in. Let's go through the layers of the epidermis, then talk about cell junctions, and then we'll cover the first half of derm pathology. Okay, first, what are the different layers of the epidermis? There's the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. And the mnemonic we like using now is, come, let's get sunburned. For corneum, lucidum, granulosum, spinosum, and basale. These are the epidermis layers. One kind of interesting thing about the epidermis is that it doesn't have any blood vessels. The epidermis gets nutrition by diffusion. And the other thing to mention here is that the stratum lucidum is only present on the palms and the soles. So remember, stratum lucidum, palms and soles. Then underneath the epidermis is the dermis. And where do blood vessels reside? These are in the dermis. And that is all we're going to say about epidermis and dermis. So moving on to epithelial cell junctions. These are at least a 3-star topic and definitely important for you to know for step 1. And there are different ways that cells adhere to one another depending on the cell type. So the zona occludens, or tight junction, this is where 2 cell membranes join together really tightly just beneath the apical surfaces and form a pretty much impermeable barrier between the cells. So this prevents diffusion across the paracellular space, or in between the cells. And though many proteins compose the tight junctions, the ones you want to remember are claudins and occludins. Claudins and occludins. The zona adherens, or intermediate junction, are located more basally than tight junctions. And this is a cell junction whose cytoplasmic face is linked to the actin cytoskeleton. So this junction serves as a bridge connecting the actin cytoskeleton of neighboring cells through direct interaction. And the molecules I want to associate with the zona adherens are the cadherins, which are calcium-dependent adhesion molecules. The macula adherens, or desmosome, not to be confused with the zona adherens we just discussed, is a small, discrete site of attachment. So desmosomes help to resist shearing forces and are found in simple and stratified squamous epithelium. And they're also found in muscle tissue where they bind muscle cells to one another. A primary adhesion protein here is desmogliin, so desmogliin with desmosome. Antibodies to this particular junction would be anti-desmosome and anti-desmogliin, which is what we see in the disease pemphigus vulgaris, which we'll talk about in the next lecture. Gap junctions allow adjacent cells to communicate for electric and metabolic functions. So what type of cell would you think would have a gap junction? Well, the cardiac cells have gap junctions. That's how your myocytes communicate electrical signals through the SA node, bundle of His, and Purkinje system. And in between the myocytes, there are gap junctions. Then connecting the epithelial cell to the basement membrane is the hemidesmosome, half a desmosome. Desmosomes connect cells to each other, but a hemidesmosome connects to the basement membrane. So one way you can remember this is hemidesmosome is a longer word, so it settles down to the bottom, to the basement membrane. Anyway, if there are antibodies against the hemidesmosomes, then you see the disease bullous pemphigoid. And again, we're going to cover that in the next video. The hemidesmosomes have integrins in them. Okay, melanocytes. Melanocytes are melanin-producing cells located in the stratum basale, the bottom layer of the epidermis. They're responsible for skin color, eye color, and hair color, and they originate from neural crest cells. Okay, we're going to move into some pathology now. And derm can be a little tough, and recognizing some of these may take a bit of repetition. So this may be a section that you need to watch more than once to remember all of it. We're starting with atopic dermatitis, also known as eczema, and some people associate it with seasonal allergies or allergic exposures like food or environmental, and it's seen more often in people with asthma and allergic rhinitis. It is very pruritic. In fact, sometimes people call it the itch that rashes, as in eczema is a pruritic area and people scratch it, which causes a worsening rash, and then it becomes even more itchy. It's a vicious cycle. Patients commonly get atopic dermatitis on skin flexures. This is like the antecubital fossa and behind the knees, and it tends to worsen during the drier months of the year, like in the winter. And you may also see this worsen in babies whose parents bathe them every day, because bathing actually dries out the skin by removing some of those natural oils. So let's talk about some of the ways you can treat atopic dermatitis. So in the study guide, how do we treat it? There are several goals: eliminating exacerbating factors like the frequent bathing, for example, then restoring the skin barrier and hydration, and then adding medications if needed for inflammation. So for hydration, you could recommend switching to a moisturizing soap or just soap less often, or adding an emollient. And then for mild cases, medical treatment would start with intermittent topical steroids for flare-ups, and many times this is all patients need. Then you could also give a topical calcineurin inhibitor like tacrolimus or pimecrolimus if the topical steroids aren't cutting it. Antihistamines can be helpful to prevent the itching, and you may need to give antibiotics if a secondary infection of the skin develops due to the scratching. Leukotriene inhibitors may provide some support for patients who also have asthma or allergic rhinitis. And then UV light therapy can help some. These lesions tend to improve in the summer and worsen in the winter for that reason. And then when it gets really bad, systemic steroids can be used temporarily to control major flare-ups and for even more refractory cases if all those things are not helping. Especially in an adult patient with severe atopic dermatitis, you could consider systemic immunosuppressants like methotrexate, cyclosporin, or azathioprine. But these drugs are really last resort, and those patients would need to be under the care of a dermatologist or an allergist. Okay, verrucae. These are warts. Soft, tan-colored, cauliflower-like lesions. Verruca vulgaris is the common wart, which can be anywhere but commonly occurs on the hands. And then there are plantar warts, or Verruca plantaris. Both are caused by human papillomavirus. The common warts are most often caused by HPV types 2 and 4. And there are several treatments for warts, although in immunocompetent people, these also will resolve without treatment most of the time. If treatment's necessary, salicylic acid, which is over-the-counter, can be applied topically, or cryotherapy with liquid nitrogen can be applied in the office setting. And then there are a whole slew of other treatments that can be tried for refractory lesions, like intralesional bleomycin, imiquimod, or surgery, but these are probably not as high yield for your exam. Okay, melanocytic nevus. This is a common mole. These skin lesions are composed of nevus cells, which are a type of melanocyte. They are benign. The majority of moles will appear during the first 2 decades of a person's life and are related to family history, but also sun exposure. Congenital moles, if they're large or giant, have a higher risk of becoming melanoma. Allergic contact dermatitis. You'll see this in the immunology section as well. So this is a T-cell mediated delayed type hypersensitivity reaction, a type 4 hypersensitivity reaction. This is like nickel allergy or poison ivy allergy. The lesions occur in skin areas that come into contact with the allergen. So with poison ivy, you may see linear patterns where the plant rubbed up against the skin. So if a question describes a very pruritic linear rash, think of allergic contact dermatitis from poison ivy. Okay, let's talk about acne, which is high yield for step 1. So you all know what acne looks like. You've probably experienced it yourself. It's characterized by areas of skin with seborrhea, comedones, papules, nodules, and even scarring. Pathophysiology. Well, there are 4 components to acne. There's hyperkeratosis, too much keratin, sebum overproduction, Propionibacterium acnes proliferation, and inflammation. So let's talk about the drugs that we use to treat acne. They're going to address one or multiple of these 4 areas. So let's talk about hyperkeratosis first. What's going to inhibit that? Well, as it turns out, this is vitamin A analogs like retinoic acid. And there are a number of topical retinoids like tretinoin or oral systemic retinoids like isotretinoin. Then you can also use topical salicylic acid or hormonal therapies like oral contraceptive pills, which can help with the hyperkeratosis as well. Sebum overproduction. So what's going to address that? Isotretinoin will also address sebum overproduction, and then hormonal therapies can help here as well. And in addition to oral contraceptives, you might also think about spironolactone. Spironolactone is a potassium-sparing diuretic, but it also has anti-androgen capabilities that can help with the acne. Then the next one, Propionibacterium acnes proliferation. What is going to inhibit that? Well, antiseptics like benzoyl peroxide, which is a first-line treatment for acne, or topical or oral antibiotics if necessary. And which antibiotics can you use? Well, topical clindamycin or erythromycin are helpful, or orally you could give tetracycline, doxycycline, or minocycline. And then the last area is inflammation, so this is more of the same. Oral isotretinoin or topical retinoids, and then the tetracycline antibiotics actually have an anti-inflammatory effect for acne in addition to the antibacterial effect. So the treatment strategy for acne is actually a bit complicated with lots of considerations for types and locations of lesions, and we're not going to cover any more of that here. Psoriasis is one that you definitely want to know. Psoriasis historically had been described as an overproduction of new skin cells with cause uncertain, although now it's believed to be more of an immune-mediated disease caused by activated T cells and dendritic cells. So what you see are papules and plaques with silvery scaling. It's one of the few things that causes a silvery scale. So if you see that on the test, think about psoriasis. Patients will very commonly have this on the knees and elbows. And if you look at the skin microscopically, you notice an increase in the stratum spinosum and a decrease in the stratum granulosum. And sometimes you'll see psoriasis associated with something called parakeratosis. This is where you see nuclei retained in the stratum corneum. So that's definitely a term you also want to associate with psoriasis. If you see parakeratotic scaling, think about psoriasis. Auspitz sign is when you have bleeding spots when the silvery scales are scraped off. Psoriasis can also be associated with pitting of the nails. The pitting will look like little divots in the nail. And then about a third of patients will also develop psoriatic arthritis. So how do you treat psoriasis? Well, we could spend all day talking about that, but here are some highlights. So the first line is non-pharmacologic. You want to moisturize the skin well with moisturizers and emollients. And then there are several topical treatments like steroids, tar-containing creams, vitamin D analogs, and retinoids. All of these attempt to normalize skin cell production and reduce inflammation. Phototherapy has been used with some success, and then there are systemic treatments like methotrexate, cyclosporin, retinoids, and nowadays the biologic response-modifying agents like adalimumab, etanercept, infliximab, and 5 or 6 others are really commonly used and can clear even severe plaque psoriasis. So, of course, the choice of treatment has to do with the type of psoriasis and severity, among other considerations. All right, that's it for the lecture. Now it's time for the end of session quiz. List the layers of the epidermis: stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. Which structure connects epithelial cells to the basement membrane? Hemidesmosomes. And what are 4 primary causes of acne? Hyperkeratosis, sebum overproduction, Propionibacterium acnes proliferation, and inflammation. And then which skin disorder matches each of the following statements? Pruritus associated with asthma is atopic dermatitis, also known as eczema. Allergy to nickel is contact dermatitis, which is a type 4 hypersensitivity. Parakeratotic scaling is seen with psoriasis, and caused by HPV types 2 and 4 are common warts. All right, that's it for Rheum Derm 7.
This is the warm-up for Rheum and Derm 8. First question, what are the normal blood pressures in the right and left ventricles? So in the right ventricle, it's about 25/5. In the left ventricle, it's about 130/10. And the last question, which primary bone tumor fits each of the following descriptions? So the most common malignant primary bone tumor of children is osteosarcoma. The most common benign bone tumor is osteochondroma. 1122 translocation is seen in Ewing sarcoma. The soap bubble appearance on X-ray is an osteoclastoma. Remember the CL for clean, like soap, and CL in osteoclast. Onion skin appearance of the bone is Ewing sarcoma. Remember onion rings and wings. And then Codman's triangle on X-ray is osteosarcoma. Remember the S in sarcoma was for sunburst, and the C in sarcoma was for Codman's triangle. All right, let's get to the lecture.
Hi everyone, and welcome to our second video on dermatology. We have a lot more skin things to talk about, so let's get going. So seborrheic keratosis. This is a common benign neoplasm. These can be flat or warty, greasy, pigmented, kind of tortoiseshell looking lesions. They look pasted or stuck on, like you could just peel them off, but you can't. Microscopically, you see proliferation of keratinocytes with the characteristic keratin-filled cysts, and you can have horn cysts as well. Overall, these are more common in older individuals, and while they can appear en masse in association with underlying malignancy in the GI tract, for example, the lesions themselves are harmless. These are not premalignant lesions, they're a cosmetic problem. Okay, now we're going to talk about some pigmented skin disorders, starting with albinism. So in this condition, there's a congenital lack of melanin pigment, and the oculocutaneous type involves the skin, eyes, and hair, and is inherited in an autosomal recessive pattern. The mechanism is a mutation in one of multiple described genes in the melanin synthesis pathway, commonly a tyrosinase enzyme responsible for the first step in that pathway. These patients have a normal number of melanocytes, but decreased melanin production due to these enzyme deficiencies. And you'll hear more about this in the amino acid disorder video. Next is vitiligo. This is much more common than albinism and is acquired rather than congenital. So with this condition, sections of the body develop complete depigmentation. So you'll see a decrease in the number of melanocytes. And again, this is different from albinism, for which there's a normal number of melanocytes but decreased melanin. Vitiligo is a decrease in the number of melanocytes. The cause is not known, but appears to have an autoimmune component and is associated with other autoimmune conditions like type 1 diabetes or Addison disease. Genetic factors seem to be involved as well. Oxidative stress and even triggering by viral infections may contribute. Okay, melasma. This is the last pigmentation condition we'll discuss. This is acquired and only patchy, like vitiligo, but it's a dark skin discoloration rather than a lack of pigmentation. And patients will have dark, irregular, kind of well-demarcated hyperpigmented macules, usually in sun-exposed areas like the cheeks or the lip, and they develop gradually over time. It's particularly common in pregnant women and those taking oral contraceptive pills or hormone replacement therapy. In fact, we call it the mask of pregnancy when we see it in a pregnant woman. It's pretty common. Around 25% of pregnant women will get it. And the pathogenesis isn't really understood, but probably is related to stimulation of melanocytes by estrogen and progesterone. And in many cases, the patches will spontaneously resolve over several months. Okay, let's go to some infectious skin conditions, starting with impetigo. Impetigo most commonly is caused by Staph aureus, but group A strep, strep pyogenes, can also be causative. This is highly contagious. The lesions are honey-colored and crusting and are common around the lips and nose of children. You can treat with topical mupirocin or retapamulin if the outbreak is mild. But for more serious infections, you can give dicloxacillin or cephalexin orally. Okay, cellulitis. This is another bacterial infection, this time of the dermis. It's painful and tender to the touch, and it can rapidly spread, and you'll see a ton of this in the hospital. Subcutaneous tissues can also be infected. So the most common pathogen here is strep pyogenes, and less often Staph aureus can be causative as well. And if the cellulitis is non-purulent, in other words, no associated abscess, and you don't suspect MRSA, then you can treat with oral dicloxacillin or cephalexin. And if you suspect MRSA, then consider using trimethoprim sulfamethoxazole or clindamycin. Necrotizing fasciitis. This is a very serious and scary infection. The infection involves the deeper layers of skin and subcutaneous tissues, and what makes it dangerous is that it can quickly spread across the fascial plane, and it's commonly caused by anaerobic bacteria or strep pyogenes. The skin here is very tender, and also the tenderness tends to extend beyond the visible area of cellulitis on the skin. You can feel crepitus from the methane and CO2 produced by the bacteria. Treatment is immediate surgical debridement and IV antibiotics like a carbapenem together with clindamycin. Staphylococcal scalded skin syndrome, SSSS. So as the name implies, this is caused by Staph aureus, and the syndrome is induced by epidermolytic exotoxins. So exotoxins A and B are released by Staph aureus, and it destroys keratinocyte attachments in the stratum granulosum. Patients will get fever and a generalized erythematous rash with sloughing of the upper layers of the epidermis. This is most often seen in newborns and children. And treatment includes antibiotics to cover staph, like nafcillin, oxacillin, or vancomycin if it's MRSA. Hairy leukoplakia. These are white patches on the side of the tongue. They're painless plaques that cannot be scraped off. They're caused by EBV, Epstein-Barr virus, in immunocompromised patients. It occurs almost entirely in HIV-infected patients. And don't get this confused with regular leukoplakia, which is a lesion in the oral cavity, not necessarily on the sides of the tongue. But it's another flat white patch that can be mistaken for thrush or lichen planus. 5 to 25% of leukoplakias are precancerous. Okay, now on to blistering skin disorders, starting with pemphigus vulgaris. This is an autoimmune chronic blistering disease, and here we see antibodies against the desmosomes. What do the desmosomes do? They connect epithelial cells together. They do not connect the cell to the basement membrane. What was the molecule that connects epithelial cells to the basement membrane? Hemidesmosomes. So here we're talking about the desmosomes. So anti-desmosome or anti-desmoglein antibodies are the antibodies here. Patients will get painful blisters, also described as flaccid, so they look wrinkly and droopy, not full of fluid and tense. And patients also can have oral lesions, which can differentiate pemphigus vulgaris from other skin blistering diseases. So that's a good one to remember. The diagnosis is suggested if there's a positive Nikolsky sign, which is separation of the epidermis upon manual stroking of the skin. But the gold standard for diagnosis is with a punch biopsy and then direct immunofluorescent staining, which will show antibodies in a reticular pattern. Microscopically, you'll see acantholysis, which is the loss of intracellular connections, which again is due to the loss of the desmosomes. Okay, another one of our PG-13 rated mnemonics. This one came from a student. Pemphigus vulgaris, damn. Damn is a vulgar word. Desmosomes, acantholysis, mouth, Nikolsky sign. Okay, now let's talk about bullous pemphigoid. So it's autoimmune with antibodies against hemidesmosomes, which connect the cells to the basement membrane. I think we've said that a few times now. You'll see eosinophils within a blister. It's similar, kind of similar clinically to pemphigus vulgaris, but tends to be less severe. And bullous pemphigoid will have a negative Nikolsky sign, and also it spares the oral mucosa. So remember that I said the oral lesions are only associated with pemphigus vulgaris. A memory tool used for the antibodies is pemphigoid, which is a longer word than pemphigus, much like hemidesmosomes is a longer word than desmosomes. Another mnemonic that might help is BPH, bullous pemphigoid, hemidesmosomes. Okay, dermatitis herpetiformis. This is a chronic blistering disease, and despite its name, it has nothing to do with the herpes virus. It's named this because the inflammation has the appearance of herpes lesions, like little itchy vesicles, and patients will present with these really intensely pruritic papules and vesicles. Direct immunofluorescence studies will show deposits of IgA in the tips of the dermal papillae, and it's associated with celiac disease, and the symptoms can worsen with the amount of gluten ingested. So a pruritic skin disorder associated with celiac disease, think about dermatitis herpetiformis. Moving on to erythema multiforme. So this is an acute onset rash, which is most studied in association with HSV infection, that's herpes simplex, but other factors also contribute. The cause is not completely understood, but it may be related to deposition of immune complexes in the superficial microvasculature of the skin and oral mucous membranes. It usually follows some infection or drug exposure, and it can vary from a very mild rash to a severe life-threatening form that's like Stevens-Johnson syndrome. And patients can present with the distinctive target-shaped lesions, but also with macules, papules, and vesicles. The rash is often pruritic, and again, this is commonly due to HSV infection or a drug reaction. Okay, then Stevens-Johnson syndrome. This is a very severe and terrifying skin condition where cell death leads to the separation of the epidermis from the dermis. This is thought to be a hypersensitivity reaction that affects not only the skin but the mucous membranes as well. So the symptoms of Stevens-Johnson include fever, bulla formation, necrosis, sloughing of the skin, and unfortunately a high mortality rate. This is one of the few dermatologic emergencies. And even more severe form of Stevens-Johnson syndrome is toxic epidermal necrolysis, or TEN. So Stevens-Johnson and TEN are essentially the same disorder, just differing magnitudes. So with TEN, at least 30% of the body surface area is sloughing and detaching. So if you have at least 30% of the body surface area sloughed off, that's TEN, toxic epidermal necrolysis, rather than Stevens-Johnson syndrome. And there are multiple drugs implicated in the cause of Stevens-Johnson. Seizure medication, sulfa drugs, penicillin, and allopurinol are some examples. All right, here are a few miscellaneous disorders. Lichen planus. So this is another disease of the mucous membranes, and the lesions look like lichens, that grow on trees, hence the name. So it's thought to be due to an autoimmune process with an unknown trigger. So when you think of lichen planus, you need to think about the P's. So these lesions are pruritic, purple, polygon-shaped papules, and plaques. On microscopic exam, you might see a sawtooth pattern of lymphocytes at the dermal-epidermal junction, and it's associated with hepatitis C. So, hepatitis C, lichen planus. Actinic keratosis. These are growths of thick, scaly, crusty skin. They're sometimes easier to feel than see. They're like sandpaper. And unlike seborrheic keratosis, those stuck-on lesions we talked about earlier, actinic keratosis are precancerous. Untreated lesions have up to 20% risk of progression to squamous cell carcinoma. They occur more commonly in fair-skinned people who get a lot of sun, and these need to be treated. So one drug that can be used for actinic keratosis is 5-fluorouracil, or cryoablation with liquid nitrogen can also be used. Acanthosis nigricans. This is a brown or black, poorly defined, velvety hyperpigmentation of the skin. And this is due to hyperplasia of the stratum spinosum. It's most commonly seen in the lateral and posterior folds of the neck, or the axillae, or the groin. And it can be associated with hyperinsulinemia, like with type 2 diabetes, and this is really common actually. But it also can be seen with visceral malignancies. So if you see a patient with new acanthosis nigricans, you definitely want to screen for diabetes. And if the patient's older than 40 years or so, you might think about a visceral malignancy as well. The skin lesion itself is harmless, just a sign of something else going on. Okay, erythema nodosum. This is a patch of inflammatory lesions of subcutaneous fat, which look like tender red nodules or lumps on the shins bilaterally. These are most common in young people between the ages of about 12 and 20 years. And erythema nodosum is commonly associated with sarcoidosis. And then you can also see in other disorders like histoplasmosis, coccidiomycosis, TB, leprosy, or group A strep infections like strep pharyngitis. And the lesions typically resolve spontaneously within 3 to 6 weeks. Okay, pityriasis rosea is an interesting one, an acute exanthem, probably viral. It starts with a herald patch, usually on the trunk or the back. It doesn't have to be on the trunk, like in this patient, it's on the arm, but classically it's on the trunk or back. It's 2 to 10 centimeters, red and oval shaped. And then days later, you see a more generalized rash of multiple small patches that tend to follow along rib lines. So you get what looks like a Christmas tree distribution. And then it remits spontaneously over 4 to 6 weeks and is benign. Sunlight can actually help the lesions resolve. Okay, before we go to cancer, let's do a quick game show to review some of these. So we have blisters, positive Nikolsky sign, and desmosomes. That's pemphigus vulgaris. Then premalignant, sandpaper-like, treat with 5-fluorouracil. That's actinic keratosis. Honey-colored crusting lesion, highly contagious, caused by staph or strep. That's impetigo. Christmas tree distribution, herald patch, sunlight improves the rash. That's pityriasis rosea. Blisters, negative Nikolsky sign, hemidesmosomes. That's bullous pemphigoid. Associated with hep C, sawtooth infiltrate of lymphocytes. Pruritic purple papules, that's lichen planus. Intensely pruritic, IgA and tips of dermal papillae associated with celiac disease, that's dermatitis herpetiformis. Okay, let's quickly move on to skin cancer. Definitely a high yield subject. This is 4 or 5 star topic. So the order of commonality of the skin cancers is basal cell, then squamous cell, and then melanoma. And then the order of metastatic risk is reversed. So melanomas have by far the most metastatic potential, and then squamous cell, and then basal cell. Squamous cell carcinoma, very common, estimated to be about 20% of non-melanoma skin cancers. Squamous cell cancers are going to appear on sun-exposed areas, typically the hands and face. It's locally invasive, but rarely metastasizes remotely. And what you'll see is a scaly patch or plaque or an ulcerative red lesion. Histologically, there will be dysplasia of the keratinocytes with the distinctive finding of keratin pearls. Basal cell carcinoma, again, these occur in sun-exposed areas, and basal cell cancers will have a rolled edge appearance with a central ulceration, or can be pearly-looking papules. And along with those pearly papules, you might see telangiectasias. And microscopically, you may see palisading nuclei. And melanoma is the last skin cancer we're going to talk about and the most scary. Like the others, it's associated with sun exposure, although it can occur in non-sun exposed areas as well. So what are the ABCDs of melanoma that would increase your suspicion for the lesion? A is for asymmetry, B is for border irregularity, C is for color, meaning multiple colors in the lesion, and D is for diameter. If the diameter is bigger than the head of a pencil, then it's suspicious for melanoma. Under the microscope, you'll see nests of melanocytes that fill the dermis and obscure the epithelial dermal junction. And the depth of the tumor correlates with the risk of metastasis. And so this is really important because when you're evaluating a skin lesion you think might be melanoma, you want to get an excisional biopsy, or at least a punch biopsy, and not a shave. If you do a shave biopsy, you're not going to be able to assess the depth of the tumor. Okay, pause the video and look at your end of session quiz and your study guide, and then we'll go through the answers together. What are some of the hallmark features of necrotizing fasciitis? The features are rapidly spreading cellulitis and cellulitis that has tenderness beyond the red border, indicating an underlying fascial infection, and then subcutaneous crepitus. And what organism causes this infection? It's either Strep pyogenes, group A strep, or an anaerobic bacteria. And what pathogen causes painless white patches on the tongue that cannot be scraped off? The pathogen is EBV, and the condition is oral hairy leukoplakia, commonly associated with HIV infection. Which skin disorder matches each of the following statements? The pruritic purple polygonal papules is lichen planus. Pruritic vesicles associated with celiac disease is dermatitis herpetiformis. Antibodies against hemidesmosomes is bullous pemphigoid. Antibodies against antidesmosome, pemphigus vulgaris. Keratin-filled cysts are seen with seborrheic keratosis. Sandpaper lesions and predisposition to squamous cell cancer is actinic keratosis. Honey crusting lesions that are common about the nose and lips is impetigo. And histology shows palisading nuclei is classic for basal cell carcinoma. Now we have a few rapid fire facts. Keratin pearls on the skin biopsy are a feature of squamous cell carcinoma, and the most common malignant skin tumor is a basal cell carcinoma. All right, that's it for Rheum and Derm 8.